Okay. Good afternoon to everyone joining us from Rwanda, the rest of Africa, and the United Kingdom, the rest of Europe, the Eastern world, and good morning to everyone joining us from the Western world. We are so happy you chose to be with us today. We have a great many things planned for you this weekend, and we can't wait to share everything with you. This conference is meant to bring light to the amputation and prosthetic services as they stand today, and to explore ways in which we can improve the services that already exist in the world. My name is Claudine Humure, and I will be your host for the next few minutes. Before I introduce our first speaker, someone who has been my mentor for the past 3 years, I would like to go through a few technical instructions for you, because we know technology can be challenging sometimes, and we want everyone to be comfortable and be able to enjoy all the benefits that this conference is offering. We hope that the discussion surrounding this conference is stimulating and extensive. Please use the Q&A function at the bottom of your Zoom screen to submit a question to the panelists. From time to time, a short poll may appear on the screen. Please answer these and be aware that your responses are anonymous. Due to the large numbers of attendees that we are unable to take verbal questions. So please use the Q&A feature. When you speak, we will not be able to hear you. But we will see your questions if you type them in the Q&A. Now, without further ado, I would like to introduce our first speaker to the stage, my former boss and mentor, and the person from whom I learned the importance of using your voice, Professor Agnes Binagwaho. Professor Binagwaho is the Vice Chancellor and co-founder of the University of Global Health Equity, where she is also a professor of pediatrics. She has served in the Rwandan government for several years, first as the Executive Secretary of Rwanda's National AIDS Control Commission, and then as Permanent Secretary of the Ministry of Health. She has also served as Rwanda's Minister of Health for 5 years. In addition, Professor Binagwaho is a senior advisor to the Director General of the World Health Organization, a senior lecturer in the Department of Global Health and Social Medicine at Harvard Medical School, and an adjunct clinical professor of pediatrics at Dartmouth Geisel School of Medicine. She is a member of the United States National Academy of Medicine and the fellow of the African Academy of Sciences. Professor Binagwaho was recently named one of the 100 most influential African women for this year, 2020. Please help me in welcoming Professor Agnes Binagwaho to the stage. Professor.
Thank you, Claudine. Thank you, Claudine, for this kind introduction, and congratulations for putting all this together with our partners. Dear students, faculty, staff, friends, and family of UGHE, it is my pleasure to welcome you to this virtual conference on transforming amputation and prosthetic service globally. We do that jointly at UGHE with our partners at Imperial College London. This weekend, we will learn from one another and share expertise in order to address and encourage discussion around the key areas of the amputee services pathway. The aim of this conference is to not only present and exchange insight surrounding research, technology, and practices in amputation and prosthetic services, but it is also to hear from global perspective of lived experience that will aid and encourage development of amputation and prosthetic care in Rwanda and the world. Globally, it is estimated that every year, 1.5 million people undergo amputation due to several reasons, such as disease, injuries, and trauma, hence the widespread need to access prosthetic services. It is imperative that we discuss this because during this unprecedented time of COVID-19, many of the diseases that make people vulnerable to limb loss also make them susceptible to COVID-19. In sub-Saharan Africa, the leading causes of amputation are reported to be tumors and trauma. However, we are seeing an increase in cardiovascular risk factors. Unfortunately, in low and middle income countries, only 5 to 15% of people who need assistive technologies, such as prosthetic, have access to them. Amputees across the world, especially in low and mid-income countries, face various challenges. Firstly, amputees lack access to key healthcare services and that prevent them from regaining mobility and function. This physical challenge creates dependency and significantly affects their capacity to earn income. Secondly, amputees experience emotional and social challenge. Avoid them to be well integrated in communities. Amputees also often suffer from the double burden of limb loss and mental health issues such as depression and post-traumatic stress disorder, which may extend up to 2 years after amputation. They also suffer from societal stigma and are ostracized by communities. Thirdly, in communities that lack disability-friendly infrastructures, amputees find it difficult to navigate their way around. This makes it difficult for them to access essential services and enjoy the facility that the community has to offer. Amputation is a critical global health concern, and we must come together in solidarity to address this important challenge. Interprofessional collaboration is needed to ensure that we develop holistic patient-centered care for amputees. This means that we need to ensure proper access to medical services and the continuum of care from the point before amputation to community integration. Using an interdisciplinary team approach, surgeons, along with other medical experts and mental health experts, don't forget them, should develop a cohesive care plan to also give more attention to the mental state of amputees and their reintegration in society. We need to raise awareness of the ability of prosthetic service to ensure that those in need know where to go to seek appropriate and affordable care. Following amputation procedures, surgeons need to work with the appropriate health professionals to ensure that patients also have access to post-discharge and follow-up care, as well as access to rehabilitative services. To mitigate the economic burden on amputees, we must strengthen national policies to ensure their access to quality education. The 2030 Agenda for Sustainable Development declares that disability should not be a reason for lack of access to development programming such as education. This is why we must work together to ensure that amputees are enrolled in school and continue their education as far as they are willing to. In our school system, we need to build better learning infrastructure to ensure that we accommodate a safe, disability-friendly learning environment. Access to education is very crucial for amputees, and will improve their socioeconomic status because they will be able to get jobs that doesn't require physical effort they cannot provide. At UGHE, we are already incorporating and encouraging holistic education and healthcare in our curriculum. We teach our students that when we care for a patient, we have to look beyond the individual case, but rather examine the larger social determinant of health. Our students are trained to look beyond the traditional margin of healthcare and integrate a holistic view of health into practice and policy making. We also empower global health professionals to be leaders and managers and use acquired knowledge and skills to solve problems and find lasting and inclusive solutions to the greatest global health challenges of today. Together, we must work to make the world more inclusive for the more than 1 billion people living with disabilities. And it's important to think about this those days because 2 days ago, we have commemorated the World Day, the world dedicated to people living with disabilities. Our value at UGHE to leave no one behind means that we must ensure amputees in our communities are listened to and given a seat at decision-making table. There is a need for community recognition of amputee identity and a commitment to transform the way we care for people with disabilities. Like everyone else, amputees are people with dreams and aspiration, and treating them differently alienates their human rights. This conference is very important because it is going to play a critical role in pushing forward the necessary conversation about amputation and prosthetic care that will bring awareness and leverage support for amputee community. It is important to use our platforms to offer support and encouragement, and we hope to give you the tools you need to use your voice effectively to improve services and ultimately the lives of amputees. Thank you all for joining us from all over the world. Thank you to be with us today to this conference, and we hope that you engage with all upcoming sessions to learn about the challenges amputees face and contribute to the potential solution. Thank you very much for your attention, and I wish all of you a very, very fruitful conference. And thank you for our partners from Imperial College London.
Thank you, Professor Binagwaho. What a moving speech. Such a great speech to kick off the conference. It is indeed important that we start those critical discussions to help improve the lives of amputees and advance the field of prosthetics. You made a really great point about interprofessional collaboration, which is very important. If you are a surgeon, you should be giving the prosthetist a seat at the table, and you should be inviting the psychologist whose evaluations will support the mental stability of the amputee. So thank you so much. And now I would like to call on stage our next speaker, Mr. Emmanuel Ndaisaba, who is the Executive Secretary of the National Council for Persons with Disabilities. Mr. Emmanuel is living with a disability himself, and he has been an advocate for persons with disabilities for such a long time in Rwanda. He holds a bachelor's degree in management and has done management work in both private and public sectors for a number of years now. Please welcome Mr. Ndaisaba.
Thank you very much. I would like to thank you all for this conference, for inviting us as NECPD. NECPD is the National Council of Persons with Disability, and I'm Executive Secretary from 2011. So thank you very much to the University of Global Health Equity and the Imperial College London for this conference. Really, even the topic of this conference, which is transforming amputation and prosthetic services globally, it's in line with our policy in Rwanda, which is we are now in NCT1, the National Strategy of Transformation. So really we need also to transform this sector because we have challenges, even if we have some key achievement, but we face some challenges. Okay, thank you. So the National Council of Persons with Disabilities in Rwanda is a public institution established in 2010 by the Constitution. And we have a mission of advocacy and mobilization and support or assist the government to implement policies and programs in place. So in Rwanda, we have I think the presenter of my presentation, the next, or I can do it myself. So amputation is the removal of all or part of a limb, such arm, leg, foot, and so on. And the prosthetic is an artificial made limb or part of the body is used to replace a part of the body that is missing, either to amputation or lack of development. Next, in Rwanda, according to the categorization of personal disabilities conducted in 2015, 2016, we have a key origin of the causes of amputation. Back to the previous slide. It was due to the congenital absence, infection, disease, diabetes, accident, and the genocide. As you know, in our country, the genocide against the Tutsi in 1994 has increased the number of persons with disability who needs prosthetics. The next. According to the census of 2012, we have 446,000 PWDs, excluding children under 5 years, and more than this number have physical impairment. It means around 220,000 persons with disabilities are physical impairment. It means there is a big number of persons with disability who needs the prosthetics. Among the above numbers, 154,000 were classified in 2 categories according to their degree of disability. Among them, 48 have a physical impairment. Here I would congratulate the Honorable Agnes, who supported the disability movement in Rwanda to make this categorization effective, because before it was not possible to do it. By his support, recognize his support, and now we have started to implement some benefits, provide laws protecting person with disability in our country. Next. Next, I think this shows you that even the person with disabilities in Rwanda, most of them have no employed. They are not employed because of level of education. So this is why they cannot afford the price of the prosthetic. That's need more facility. It means the government or partners have to put more effort jointly to support those persons, because most of them are poor. They have no capacity to afford the price of those assistive devices. Next. The person with abilities already categorized. As you see, it is more or around 30% of the population with the disabilities. So we have found that the lower limb amputation, there are 3,000 persons with disabilities. Upper limb amputation, there is 3. But I think we are now struggling to see how we can categorize the remaining person with disabilities in order to have a clear number of person with disabilities who need prosthetic. But even if we have this number, we are not able to support them, how to provide them to their needs, to make them rehabilitated. That is the challenge we have now. The number is, for us, is big, as we cannot make sure they get all they need to make them able to facilitate them to be in the development of our country and to solve their own problem. Next. Actually, in our country, we have only 15 orthopedic workshops, and only 3 of them use health insurance, the best health insurance. And here we have a challenge, because most of our client of our target group, they are in the families who are poor, which use this health insurance system. So if they are not able to access to this insurance, these facilities, it is a big challenge that we have. Other health insurance, there is no problem. And we are working with the Ministry of Health and the RSSB, Rwanda Social Security Board, to make sure all amputees at least can afford or can be supported using this health insurance. And within those 15 orthopedic workshops, only 4 are public, 4 semi-public, and 7 are private. So those only 3 who use this health insurance to support those poor persons, they are only for the government, like the the CHUB, it means for the University of Rwanda, in southern province and in the city of Kigali, only they are able to support or to provide those facilities. So the CBHI cover in general some assistive technology products, crutches, ortheses, and prostheses low-tech and locally made. Normally, person with disabilities in need of prosthetic receive them through support from government or donors and other through CBHI at two teaching hospital we have, CHUK and the CHUB. Next. In the last 10 years, NCPD, or the National Council of Persons with Disability, supported the 10 orthopedic workshops with 160 million Rwandan francs to strengthen the capacity of those orthopedic workshops. This is the reason why it's that they have a limited capacity in producing those rehabilitation materials. That's why we have chosen with our limited budget to support them, and some of them has increased the quality and the quantity also. So addition to that, a list of materials, including those of prosthetic, developed with a purpose for tax exemption so that anyone to invest in abroad will reduce the price for the prosthetic users. So we have sent this list to the Ministry of Finance, and they are in analysis to approve it. So this will facilitate our orthopedic workshop to get the raw materials, because all are from outside of our country, on a cheap price, and then our supporters, including the RSSB, the Rwanda Social Security Board, normally they say the prosthetics are the cost is very high. I think if we start to make them tax exempt, the price will be reduced, and the product should be affordable for our targeted group. Next. 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 So the National Council of Persons with Disabilities actually is developing, back to the slide, please, is developing a DMIS, Disability Management Information System, because we needed to have data for all persons in our country, and we know their need. Also, if the number of persons who need these assistive devices will be known in this, and then it should facilitate in planning and in supporting for those persons. So this tool helps us to identify real person with disabilities in need and to make a plan decision making for the promotion of assistive technology and other needs for person with the disabilities. So we have also a support from the URA, the University of Rwanda, because after our advocacy, the University of Rwanda has opened a College of Medicine, a Department of Health Science, a Department of Prosthetic Orthotics, and now we have, in general, 63 technicians in orthopedic and prosthetic, and in those 63, 53 are a URA product, and we have now 7 in a class. So take the, but even if we have 53 already finished the studies, in work, we have only 19. So this means we need to make sure that all those products of the University of Rwanda can go on work, because we have a lot of skilled technician in those orthopedic workshops. And the government also have to support those private orthopedic workshop in order to make available assistive devices for person with amputees. So that's, as you know, disability is a combination of impairment and barriers. So we have to remove those barriers to make those person with disabilities able to do everything. And I think University of Global Health, Equity and Imperial College London have to support more, because we need to have good technicians, good doctors in amputation, and also more equipment in those orthopedic workshops. Thank you very much.
Thank you, Mr. Ndaisaba, for such a great overall view of how disabilities support stands today in Rwanda and how many amputees are accounted for. You made a great point showing us how many amputees are accounted for. So it seems like the causes of amputation are really high, but we have only accounted for 6,844. This is why this conference is important. This discussion is important. It's important that we have these conversations so that the other amputees in the country are also accounted for, because numbers tell a story, and we need to speak for even those at the bottom who may not be spoken for. Thank you so much for your time. Now I'll hand it over to Dave for the next session.
Thank you.
Thank you very much, Emmanuel. Thank you, Claudine, for handing over to me. I think personally that was a great start to a session, really setting out the need and the requirement for such an event as we're hosting today. You know, it's so important to remember that people, I guess, are at the end. You know, we can talk all we want about amputation, but really we're talking about people, individuals with needs and requirements. And the amputee is the person that all of these services affect. They should be consulted and they should be given a voice. So in this next session, taking us until about 4:15, we're going to hear from 3 amputees themselves and hear their own personal stories. We're going to hear from Joseph. We're going to hear back from Claudine about her own experiences, and we're going to hear from Giles Dooley. But first, let me share a piece from Joseph.
Nitwa Bizimana Joseph, ndi umunyarwanda, navukiye mu ntara y'Amajyepfo mu karere ka Ruhango, umurenge wa Byimana. Nkorera mu ntara y'Amajyaruguru mu karere ka Burera, umurenge wa Butaro, mu bitaro bya Butaro, nk'umurabo technician aho maze kuhakorera imyaka 3. Nakoze impanuka yo mu muhanda irambabaza cyane. Twahuye n'imodoka turi kuri moto, iradukubita iradushenjaga rwo twari abantu 2, mugenzi wanjye ahasiga ubuzima. Nageze kwa muganga baramfasha, bayageza kumvura uko bashoboye, ariko bitewe n'akaguru kanjye kari kangiritse cyane, akaguru k'iburyo, biba ngombwa ko bafata umwanzuro kuba bagakuraho. Umwanzuro wambabaje ko numvaga kongeye kumugara mfite imyaka 15 nkatakaza ukuguru numvaga ari ubuzima bungoye cyane bitewe n'uko nari ntarabona abandi bantu bamugaye ngo menye ko ibyo bintu bibaho. Ubwo abaganga banje iruhande barantegura mu mutwe baranganiriza bambwira ko ibyiza ari uko kumvura nkakira neza akaguru bagakuraho kuko nta wundi mwanzuro bitewe n'uko amaneri ajyana amaraso mu gice cyo hasi ngo yari yangiritse. Akaguru kari karabaye ko umukara ubona ko bigoye cyane kuba kakira. Ubwo baraje barantegura bambwira uburyo operasiyo izagenda, bambwira ibyo ngomba kwitondera, bambwira ko ngomba kumara amasaha 8 nta kintu ndya nta kintu nywa kugira ngo bizabashe kugenda neza. Bwarakeye mu gitondo cya kare nka saa 12 banjyana muri salle dope barantegura bankorera ibizamini, hanyuma bantera ikinya barambaze kakaguru kari karangiritse cyane bagakuraho barampfuka neza akandi bagashyiramo tije cyangwa se kuru kugira ngo ibashe gufata rya gufa ryari ryaracitse. Ubwo bankuye muri salle dope banshyira muri recovery room, niciye numva mbabara mfite icyaka mfite inzara bitewe n'aya masaha 8 namaze ntarya ntananywa. Numva ni ibintu bigoye nkareba nkabona akaguru ntakariho nkumva ububabare. Ubwo nza kuva muri recovery room banjyana ku gitanda aho narindi aho naryamaga. Nasanze abantu mu muryango wanjye bababaye cyane bandeba nanjye nkumva mfite agahinda, ariko mama wanjye nk'umubyeyi aranyitegereza arambwira ati humura uzakira, kuva uri kwa muganga kuva utaraguye hariya impanuka yabereye uzakire, Imana izagufasha uzakira. Numva nshibijemo imbaraga cyane ndishima numva ni byiza. Ubwo nabaye aho kwa muganga muri CHK amezi 6 bantegeka kujya njya gukora physiotherapy igatagara. Nageze igatagara mpasanga abandi bantu benshi bafite ubumuga bakajya banganiriza kumva ndagenda ngarura ibyiringiro. Nageze amahirwe igatagara nkabona umuterankunga angurira iyo proteze ndetse ananyishyurira amafaranga nari maze kuhivuriza. Ubwo nyuma yo kubona proteze narishimye numva ubuzima burakomeje njya no kwiga. Birumvikana nk'umuntu wari waragize icyo kibazo cy'impanuka nari umunyeshuri byatumye ngira byateye impact ikomeye ku buzima bwanjye bwo kwiga. Urumva nakerereho umwaka, urumva nk'umuntu wari ufite ubumuga nkasubira ku ishuri performance yaragabanutse, ariko buke buke bigenda biza nongera gusubira kuri performance ndiga neza ndatsinda. N'ikimenyimenyi ubu ngubu mfite lisansi nakuye muri kaminuza y'u Rwanda mu ishuri ry'ubuvuzi. Ni ikintu nashimiye Imana, ngishimira n'abagiye bangira inama n'abagiye bankomeza cyane. Ubu rero ubuzima bwarakomeje numva ntuje ubuzima busanzwe mbasha kugira ibyo nikorera mu kazi kanjye ka buri munsi, nubwo hatabura imbogamizi ariko ngerageza kugakora neza. Mu kazi kanjye ko muri laboratoire nk'umuntu ufite ubumuga hari ibibazo njya mpura nabyo. Hariho nk'igihe baba bakorobye bitewe n'uko ahantu hakorobye haba hameze isabune, urumva ngo bisaba kwigengesera. Hakabaho nk'igihe nko nshaka kujya gufata ibizamini nk'ahantu yenda hasa nko mu mawadi runaka, bigasa nk'aho bincarenginga aho gatoya, ariko bitewe n'uko mba mfite proteze bibasha gukunda. Nk'umuntu ufite ubumuga hari ikintu numva nakoraho ubuvugizi, kujya kubaga umuntu bagiye kumuca nk'akaguru, kuba haba hari abasurgeon hakaba n'abatekinisiye bakora proteze, byafasha kugira ngo umuntu azakorwe insimburangingo igendanye n'aho bamuciriye akaguru cyangwa se urundi rugingo. ikintu numva nakoraho ubuvugizi ku bantu badafite ubushobozi poroteze bagiye bazihererwa ubuntu bakabasha kugira amahirwe yo kuba bazitunga nabo. Ikindi, abantu bafite ubushobozi bukeya, poroteze igiye yishyurwa kuri mituweli byabafasha bakoroherwa n'igiciro. Ikindi kintu numva cy'ingenzi cyagombye gukora investment muri tekinoloji mu gukora poroteze, ikaba igendanye n'uko umuntu amugaye, icyo akora, aho ari n'imirimo ye ya buri munsi. Dufashe nk'urugero, nk'ubu njyewe nkorera inaha i Butaro mu misozi miremire, ahari imihanda itari myiza, aho imvura igwa ugasanga hanyereye, habaho n'igihe nyerera nkaba nakikubita hasi poroteze ikangirika. Ubwo yangiritse biba ngombwa ko njya kuyikoresha inshuro nyinshi. Ubwo urumva nk'iyo ngiyeyo hari umwanya ntakaza, ahari serivisi nagomba guha abarwayi, nagomba gutanga nk'umuntu ukora kwa muganga, ahari amatike nkoresha no kwishyura, n'ubwo byose bitwara amafaranga menshi no kumvuna mu mutwe, bigatuma mba natekanye. Reka ndangize nshimira kaminuza ya UGHE na Imperial College London zafashe mu kuorganiza iyi conference ku buvugizi bw'abantu bafite ubumuga. Murakoze.
Joseph, thank you so much for sharing your story with us today. It's really, really good to hear that. And thank you very much for joining us for the Q&A session later on. It's very, very kind of you. Next, I would like to introduce someone who you've seen already today, the Partnership Coordinator at the University of Global Health Equity, Claudine Humere.
Thank you, Dev. So I thought it would be better if I told my story through slides. So hi again, everyone. I'm Claudine Humure, and I work at the University of Global Health Equity as a partnership coordinator. And this is my story of becoming an amputee and living with an amputation. So I've been an amputee for about 15 years, and for the same number of years, I've used a prosthesis. And but next slide, please. The way I lost my leg, I lost my right leg above the knee from cancer. And I was diagnosed in Rwanda in 2005. And basically, I had been sick for about 8 months before my diagnosis. And then I was diagnosed like today, it was like evening on a Sunday. And then the next day, they were like, we have to amputate your leg the next day. At that time, I didn't really understand why everything was so rushed. I just thought that the doctors hated me, but it had to be done because the cancer had gone to my lungs and was already going to other parts of my body. So the amputation had to be done right away. And then, so it was like a very traumatic experience for me, just because everything happened so quickly and I had no time to process anything. And then a week after my amputation, I had to go to the US to get cancer treatment. And that's because at the time we didn't have any cancer care. There was no oncology care in the whole of Rwanda, but now we have a beautiful cancer center in Butaro, which you will get to hear about tomorrow during the education session. But thankfully, we now have a cancer center. But at the time in 2005, when I was sick, we didn't. And so I had to go to the US for cancer treatment. And when I was there, I got a prosthetic leg. When I got my first prosthetic leg, I couldn't wear it because the way my amputation was done, it was done in a way that did not accommodate a prosthetic leg. So when I wore it, it really like, the bone was like a little bit protruding. It pulled on the skin too much to the point where like the bone almost ripped out. And so I had to get a revised amputation for me to be able to wear a prosthesis. And this part for me, like this whole experience of going through a revised amputation was another traumatic experience, because who wants to go through another amputation after they have been through another? So this is why the point Professor Agnes Finagwaho made about interprofessional collaboration is important, because if my surgeon at the time who did my first amputation had known about prosthetic limbs, he would have done it in a way where I would have been healed at the first time and worn a prosthetic leg and not had any troubles. But because he may not have been informed about the existence of prosthetic legs and prosthetic limbs in general, he just did the amputation the best way he knew how to as a surgeon. Anyways, after my cancer treatment, I returned to Rwanda and I had a nice prosthesis that I came back with. But actually, fun fact, I guess it's not a fun fact. When I was at school in Rwanda, I fell down when I was playing with my friends and my prosthetic leg broke, like the whole socket. Like if you don't know what a socket is it's the part of the prosthesis that comes in direct contact with the body, the remaining part of your limb. So that part broke, and I spent like maybe a whole month or two looking for someone in Rwanda who could fix my prosthesis. And I did find people, but it was really hard to find someone who could make it as high quality as the way they had made it in the US. So again, I had to return to the US to get a properly fitted prosthesis that gave me like the kind of independence that the first one was giving me. And that like just like gave me a glimpse of like how things work in Rwanda and how much we need to encourage more education in this field, and so that we can have like a lot more experienced prosthetists and orthotists. Next slide, please. So in the next slide, this is the first picture. It's my leg, the way it was before my amputation. And this is just to show that even though, yes, it was like a very traumatic experience, but like later on as I grew up, I came to understand that if I hadn't lost my leg, I would have died and I wouldn't be here like talking to you guys about this. So I'm grateful that I got given a second chance, even though it was like a horrendous experience. This other picture is me after I had already gotten my like revised amputation. And that's my friend Karen. She also had cancer at the same time, but unfortunately she didn't survive the cancer. Next slide, please. So as I said, I am from Rwanda, which is a very small country about the size of Maryland. It is located pretty much at the heart of Africa. It has a population size of 12 million people. It's one of the densely populated countries in the world. And next slide, please. And it's very, very mountainous. It's very hilly. I feel like everywhere you go in Rwanda, you have to climb a slope or like go down a slope or something. It's the reason I want to bring up the hilliness of the country is just to show that as a person living with an amputation, sometimes it's hard to navigate the country when you have like a lower extremity amputation. So this is to encourage the prosthetic researchers and other prosthetic professionals who are following us today that please like always be mindful of like the terrains we will be working on, because I hear a lot of people coming into this field and they come in and they want to say they are going to design prosthetics for people in low and middle income country. I just want to remind everyone that low and middle income countries are very diverse. A prosthetic leg that works for someone in Rwanda might not work for someone in Somalia, and vice versa. And so it's important that we encourage collaboration, and that when we are designing these prosthetic limbs, we always think of the user and think of where they are going home to, or where they will be using this technology. Next slide, please. And this is like just another evidence of like how gorgeous Rwanda is. It's beautiful, everyone should visit, but also look at how hilly it is. I was sweating by the time I climbed this hill, and I have a prosthesis that's considered to be one of the best. It's a steel leg fourth generation. It's really good. It gives me a high independence that I see a lot of my amputee friends in Rwanda are not able to accomplish. So my hope is that this conference will inspire designers, prosthetic researchers, orthotists and prosthetists to design high quality prosthetic limbs that are affordable, that can be available to everyone, so that people in Rwanda and other countries can also be able to enjoy the beauty of their countries without struggling or having to not go to the market just because they feel like by the time they come back home, the prosthetic device they have will cause like blisters or will injure them, and they won't be able to like, you know, enjoy everything. Anyways, thank you so much for listening to my story. And yeah, that's my... Yeah, this is where I end. Thank you. Thank you, UGHE and Imperial, for the platform to share my story.
Claudine, thank you ever so much. I've heard your story a few times now as we've worked together over the last few months on different projects. I'm always struck by your humility and your positive outlook to life. It really is encouraging to see that. So thank you. I was also struck here by, you know, I feel very lucky in the UK that I don't really have to consider necessarily the terrain in which I'm walking. And I often forget that the situation where I am is not necessarily the situation where someone else is. So again, you know, speaking personally as an engineer, it's very good to hear that perspective. So thanks for sharing, and we'll come back to you shortly with some questions. Our next speaker is a personal friend of mine, Mr. Giles Dooley, a humanitarian photographer with an exceptional story. I won't steal your sandwiches, Giles, so I'll hand straight over to you. Thank you for joining us.
It's a pleasure to be here, Dave, and great to see many of people I know, both at Imperial and in Rwanda. Rwanda is a country that I have visited many times. My NGO, my charity, has projects there as well. So it's a country very close to my heart and a place that I've enjoyed visiting many times and hope to be there again soon. I'm just going to keep my talk quite briefly and just slightly an overview. I work as a photographer documenting the impact of conflict around the world. And in that work, I meet many, many people who have lost limbs, mainly due to conflict, but also for other reasons. And I just wanted to share just really a couple of stories and also to change maybe a way of looking at amputees, to change the perspective slightly. I'm just going to bring up a couple of photographs of my work. As I say, I have traveled the world documenting the impact of war, and as that includes many amputees from South Sudan to Laos, Vietnam, Iraq, and Rwanda. I have seen how people have had to deal with some of the most basic prostheses you can imagine. These were from Laos. If you can imagine people having to use these prostheses for their whole life. I have been overwhelmed by people's resilience and strength. This is my friend Faid in Lebanon, who's a Syrian refugee who lost his limbs and is always laughing, always smiling. And really, that's really what I wanted to focus on, was not the negative connotations of amputation, but actually the positives, the idea of resilience. And I'm going to come back to that in a minute, but I wanted to just share two more detailed stories that maybe explain a little bit about my work, and I'm sure the motivations for many people here at this conference today. This is a photograph I took in 2012 in Afghanistan of a young boy called Atola. Atola had been walking to school when he stepped on a landmine that had been planted there. He lost his left arm and his left leg. When I met him, he was at the ICRC Limb Fitting Center in Kabul, and he was learning to use his prosthesis. People ask me, when you take photographs, do you ever find it so upsetting? Do you ever cry? And I say, no, normally, I guess like a surgeon, when I'm working, I don't really make that human connection. I just try and do my job. But on this particular day, I was struggling. I was watching Atola through the lens of my camera, and it was as if he didn't see me. He was in his own world. And I remember thinking to myself, why should a young boy have to go through this experience simply because he was walking to school one day? And the reason it particularly resonated with me is that he had been injured in Kandahar in 2011. And that is my story as well. I had been injured, in fact, just a few miles away from where Atola was injured, and just a couple of months later. So what I was thinking when I was taking Atola's photograph was that why should a young boy have to go through what I go through? Why should he have to wake up in pain? Why should he have to struggle for the rest of his life to get prostheses that fit, to be able to be seen with dignity, to be able to work in his country? Simply because, as I say, he was going to school. And when people ask me, why do I still do the work that I do, having been injured myself, I always refer to Atola's story. And as I say, I'm sure that will resonate with many people at this conference for why we do what we do. Our hope is that children like Atola get to live full lives, because that's the opportunity that I have been given. It's purely by luck that I was in a country that was able to give me the prosthesis that I needed, the rehabilitation that I needed, the other support that I needed, so that I could return to life and live a full life, even though I am a triple amputee. And I'm going to go back to this idea of resilience. You know, we are trying to focus this conference squarely on the amputee, and I think that's incredibly important. But there's still a sense, often I find, that people are seen as the victims, as the people that needed to be helped. And I think sometimes we can flip that. This is a young boy called Dawood. Dawood was injured in Mosul during the fighting for the city a few years ago. He lost both his leg and left arm. In fact, the same injuries that I have. But whenever I saw him in hospital, he was always smiling, making a joke. And on the final day, as I was leaving, he put up his fingers in a victory sign for me. And this really struck me, because at the moment, many of us are dealing with issues around the world due to COVID. And I get asked many times by people, how can I become more resilient? Resilience is an attribute that many, many people are looking for. I know personally in the UK, many people feel they don't have enough resilience. And knowing my story, knowing the stories of the people I photographed, I get asked, how can I be more resilient? And my answer is, we cannot make ourselves more resilient. Resilience, I believe, is life's gift for suffering. Resilience is what we get at the end of incredibly difficult experiences. And what I know from my personal experience and from the experiences of people like Dawood, Atola, and the many, many other amputees I've met and documented is their resilience, our resilience, is incredible. And so what I would say to other people working in this sector, people who are supporting amputees to get their life back, remember that we have one resource that everybody is after at the moment, the resource of resilience. And if we can be seen for that strength, then maybe it creates a sort of balance between what we have lost and what we have gained. Because I see that through my life. I may have lost 3 limbs, but I have been given the gift of resilience, which enables me to do things that many others can't. Thank you.
Giles, it's always a pleasure to hear you speak. Always, always, always. I've heard you many times, and only occasionally is it boring. I'm joking. It never gets boring. Thank you very much for being here. If I could ask Claudine and Mr. Joseph to turn your videos back on. We'll just take a few questions as we move into the next session, and hopefully a little bit of discussion could be encouraged here. So Giles, you've just spoken, so I'll come to you straight away. I love your work. Your photographs are absolutely beautiful. But what role does your photography play in encouraging open, action-orientated discussion around the barriers faced by amputees in different cultural contexts?
You know, I think really getting back to what I was trying to say is this attribute of resilience. And, you know, as a photographer, I look at the work of many other photographers doing similar things. And too often, amputees and those living with disabilities are portrayed in some way as victims. And my work, even before I got injured, was to try and show the other sides. And increasingly, obviously, having gone through a similar experience myself, I see it very much that way. So when I photograph somebody, I photograph the person I find in front of me, not their injuries. And I'm sure every person who is an amputee on this conference today will be very, very aware that sometimes our injuries, our amputations can overshadow who we are. You know, that we can be referred to as an amputee first and then our names afterwards. And what I try and do with my photography is to reflect the people themselves. So in fact, many times you'll see in my photographs, you would not know that person was an amputee. You know, you just see somebody living a full life, maybe in difficult circumstances, but the joy, the love, the laughter. And those are the things that I try and show. And through that, I'm trying to, I say, reframe this idea that yes, we may live as amputees, we may live with disabilities, but we are people first and we are like everybody else. And in fact, we have those strengths like resilience that maybe is an attribute that others would like to learn from us.
Yeah, I think that's really key. It's understanding about resilience. In my own personal experiences, I don't think necessarily that I ever felt I was a resilient person until my injuries came about and I was forced to really recognize what it was that I could do and push myself forward. Thanks for that. I'll pass the question over to Claudine now. Claudine, how can individuals who are not directly involved in the amputation and prosthetic space help advocate for more accessible quality services to help support amputees?
Thank you, Dave. So I think there are so many ways to advocate. First, I will start with like the people in like media, like Hollywood, because what we watch, what we see really like contributes to how we treat the people around us. And I feel like there is like a whole stigma surrounding like people with disabilities in general. And it's in some countries, it's greater than others. So I would love for like people who have the power or the television platforms to show the amputees in different light, because right now we are shown as the heroes and it's usually everything is centered around our amputation. You are not like a hero in like science or something, you are a hero just because you lost your limb. And I think we need to change that language and, you know, show the human side of who we are, because we are not just an amputee and we were human beings before we lost our limbs. And and I think it's just like I said before, getting comfortable with talking about these things and just treating us as people. And it starts there, really. I think it starts there.
Yeah, I think I can really empathize with that. There's been so many times here in the UK, and I'm sure Giles will back me up on this, where people have come up to you in the street and called you a hero, seemingly for getting out of bed that day, which I never quite understood. For me, I was very unfortunate to lose my legs, but I would never consider myself unlucky in the situation that I was in, that Giles was in, Claudine, that you were in, and indeed the situation that Joseph was in. The choice was I would either die or I would live and I would happen to have some amputations. So I never consider myself to be unlucky. I always consider myself to be lucky. And of course I would get out of bed, and of course I would push on, because life is for living, regardless of your physical condition and the limitations of that physical condition. But I do find it strange that people take such inspiration for something that perhaps is so normal for us. But I'll never get my head around it. Definitely a person first, and the amputation is just happenstance.
Yeah. The other thing I would add, like in terms of infrastructure, I would just encourage like people who are in the infrastructure, or like if you're going to start a restaurant or you're going to build something, just like consult someone in the business, like, or consult a person with that physical disability, or like someone who will have to use the wheelchair and walk up that ramp. Because sometimes I will work in some countries and I will find that, yes, they tried to be like accessible, but the ramp they made is too steep. And if you like walk up on it on your prosthesis, you still have to like hold on to someone, or if you are in a wheelchair, you might like tilt back. And sometimes they have like those sensors for the doors, and they're like too high for some people in wheelchairs, for example, to reach. And so just like consult the people that you are designing these things for, so that you can actually design something that works, instead of wasting time on something that might not serve anyone.
Absolutely, 100% support that. Giles, another one for you. Claudine spoke about Rwanda being a country of mountains. Is there any experience of this from your side?
Yeah, I have experienced the wonderful, beautiful, lush mountains of Rwanda, and have slipped over many times in the mud and had experiences like that. But it is an important point. You know, exactly that. You know, I'm fortunate in that I get to travel around the world. Last year I was in 19 countries, and I see the different, challenges. For example, you might be in South Sudan, where it's flat, but it's incredibly hot, incredibly dusty, and you get problems with your prosthesis for that. You may be in Rwanda, where it's the slopes, the mud can be another problem. And we have to always look at specifics for what is needed in that country. My need right from the beginning, I always just said, I want to get from A to B. I wasn't particularly worried about my gait and everything being perfect. I knew I was going to be working in challenging places. I wanted a prosthesis that would be able to work in all sorts of different circumstances. I used to say, I want one that can be repaired in a bicycle repair shop. And that's what I needed for the work that I do when I'm traveling. And I think we do have to listen again to the user, because again and again, I still see it, that people with full of good intentions, they come up with an idea, they sit in a laboratory, they come up with some research, something that they think is going to be fantastic for everybody, without having ever actually really listened to the user to ask what it is that they need. And I think we have to keep pushing that all the time, that we are the ones that deal with using these prostheses on a daily basis. We have the needs. It may not be, as I say, that we're particularly worried about the gait or whatever it is. Everybody has different needs, but let's focus on listening to the user first and what their needs are, and then building components for that particular person.
Perfect answer. Thank you ever so much for that, Giles. Joseph, I have a question for you. How do you think healthcare providers can better collaborate collectively to provide better services for amputees?
Because prosthesis is very important, that's why I'd like to request to invest in technologically to do prosthesis which is personalized to people. Due to their daily activity, it will help people to work freely.
Thank you, Joseph. Very much appreciated. Claudine, I wondered if you might say anything about whether there's a difference between males, females, whether the effect of amputation could be considered differently in that space?
Well, considering the case of Rwanda, I would say everyone is right now, everyone is being affected the same in this field of prosthetics and orthotics, because as Mr. Emmanuel Ndaisaba just pointed out, we have like only 15 orthopedic centers, which here we call them orthopedic centers, but in some countries they say prosthetics and orthotics clinics. They're like very few, and those are like the ones that serve all of us. So I would say there are no disparities right now that are visible, and even if there are, it's not recorded. We don't really know what's happening in places we are not seeing. So right now, I would say there isn't that much of a difference. Yeah.
Thank you, Claudine. Giles, I think this is probably going to be the final question before we move on to our next session on amputation surgery. But this is something, you and I were in a meeting the other day, Giles, and it's something that came up there. Can lessons around the provision of care, surgery and rehabilitation be shared across countries? Or do you think that a tailored response is needed for each country? Obviously, you've traveled far and wide and seen many different things.
Yeah, I mean, obviously, things have to be taken into context culturally. You know, the experience, for example, you know, Claudine was just talking about what it's the experience for, you know, a woman living in Rwanda, and the difference between that. It's very different if, for example, you're in a country such as Iraq, you know, for a woman with a prosthesis. It can be very, very challenging in different ways because of her access to, for example, she would not be able to go and see a male consultant. So there's things that have to be taken into consideration. But overall, I think, you know, my mantra when I got injured, and the mantra of everybody that I have met who has lost a limb for whatever reason, has always been, I just want my life back. And, you know, that is the goal that all of us have ever wanted, I think, is to be able to return to a life that we had before. And so what I would say is, for all the technicians, the surgeons, everybody, remember the person before they were an amputee, and work with that person and try and find the solutions to help them, you know, enable them to get back to who they were before. Because, yeah, we will never be the same. In fact, we will probably be better in some ways. We have this greater resilience, we have greater experience, but our goal is the same. And I think that is the universal message for everybody I meet, is whatever it was that they were doing before, they just want to be able to find a way to return to that. And if we remember that is the single goal, and that we're all working to that end, then I think that is the universal sort of message that would come from amputees to all the specialists working with them. So that would be the universal.
Giles, thank you. Always incredible insight from yourselves. And I'd just like to say a final thank you to all three of our speakers, Giles, Claudine and Joseph, in this session. For me personally, it's been incredibly enlightening, and thank you very much for giving up your time to be with us today. Thank you very much.
Pleasure. Thank you.
Thank you, Dave.
Most welcome.
Thank you. Okay, so it's now 4:15 Central Africa time, and we'll move on to our next session. Our next session is all around amputation surgery, and this session will be moderated by Dean Jean-Claude Birangiro. He is the Dean of the School of Medicine and Pharmacy at the University of Rwanda, and a consultant surgeon. Jean-Claude, it's an absolute pleasure to have you here with us today. Over to you, please.
Thank you, Dave. And a big thanks to all previous speakers for such important presentations and sharing of experience. Do you get me well?
Very well.
Yes, yes.
Thank you. It's really a great honor for me to be part of this important conference. Please allow me to thank the University of Global Health Equity and Imperial College London for bringing us together to start this overdue conversation. As Dr. David said, my name is Jean-Claude Birangiro, and I'm an orthopedic surgeon by training, and I'm currently the Dean at the School of Medicine and Pharmacy of the University of Rwanda. I will be moderating this session for the next hour with our esteemed speakers, Dr. Stina and Shehan Etiaratke. I hope I'm pronouncing well the name. I would like to call Kano Dan Stina on the stage to present about different types of amputation. And as a little background on Kano Dan Stina, is an orthopedic trauma surgeon in the US Army with extensive experience as a surgeon on combat operation in Afghanistan and in the US at the Brooke Army Medical Center, San Antonio. Dan, over to you.
Great, I appreciate the introduction. Just want to make sure you can hear me okay.
Sounding
Yes,
good, Dan.
Great. So I'd first like to thank the organizers of this event for giving me an opportunity to present. I'll do the best I can within 10 minutes to hopefully give you all a cursory overview of traumatic limb amputation and perhaps some tips should you find yourself having to make that decision to amputate a limb. All right, next slide, Dave. And next slide, Dave. Right, so these are my views and my views only and do not reflect the views of the United States government, Department of Defense, or US Army. Next slide. And in the interest of full disclosure, I do have a bias. I consider myself to be a limb salvage surgeon, but as an orthopedic trauma surgeon, I have found myself doing my fair share of amputations. Next slide. As many of you know, there's a spectrum of injury between limb salvage and amputation. Next slide. And often the factor that drives us down one path or the other is driven by the extent of the soft tissue injury. Next slide. For those of us that have taken care of these types of injuries, there's a wide spectrum of these soft tissue injuries that might drive us towards the amputation or the limb salvage, as you can see here. Next slide, please. And when we're trying to make that decision of whether or not to amputate, sometimes it's easy, as it is here. You can hit advance, advance. Next slide. But sometimes it's more complicated. In an effort to try and simplify this decision-making process, we published an algorithm in the textbook Skeletal Trauma just to help try and guide the surgeon on the initial management of the patient with the limb at risk. And if you can just follow this algorithm down, you see a patient stable or not stable. And if they're stable, then a lot of the next decision kind of just depends on whether or not they have a vascular injury and then whether or not the terminal extremity is good or salvageable. And if it's not, we're going to proceed with amputation. If it is salvageable, we're going to do the best we can to perform limb salvage. But as you can see to the right of this algorithm, if the patient's unstable, the primary thing that we need to be concerned about is saving that patient's life, and the limb becomes second of importance. Next slide. All right, so I'm just going to take you down a typical sort of case scenario. So if this patient's hemodynamically stable, has a vascular injury, but does have a good terminal extremity, we should be stabilizing the limb and performing a vascular repair. Next slide, please. And you can see this here. So this is a patient of mine. They had a ballistic injury to the distal femur with a popliteal artery injury. I stabilized the limb using an external fixator. And I have some pictures of one of the external fixators that Imperial has developed as a low-cost alternative to some of the other commercially available external fixators. So this limb was stabilized in 12 minutes. So something we can do very rapidly. Then we perform the vascular repair to get the limb perfused. And then several days later, I'll come back and do my definitive fixation. Because the overall goal, again, here is to get the limb reperfused and stabilized in an efficient manner. Next slide, please. Okay, but again, here our goal is to focus and talk about amputation. And just as I mentioned before, as we work our way down this algorithm, if the patient doesn't have a good terminal extremity, patient's going to end up with an amputation. Next slide, please. And I think one of the important things, just as it was brought up before, is that amputation should be considered a reconstructive procedure. I think often in the world of orthopedics and surgery, we tend to be discouraged when we're performing an amputation and potentially don't put as much time and effort in performing a good reconstructive surgery to give that patient that best outcome. And what I like to say is that amputation surgery is not hard, but next slide. It is very easy to perform poorly, and complications are common, especially following trauma, to include problems with wound healing, pain, difficulties with prosthetic fitting, all of which may require additional surgery. And I think just as Giles spoke of in the previous session, the amputee wants their life back. And our job as the surgeon is to give them the best chance of getting back to the functional level they wish to achieve as quickly as possible. Next slide, please. Okay, so let's talk about some general principles of amputation. Next slide. So again, the initial management in the trauma setting should always follow ATLS, Advanced Trauma Life Support algorithm. So we focus on the airway, breathing, circulation. So it's always life over limb. Make sure the patient is going to survive before we worry about that limb. We want to obtain hemostasis. Often this only requires a tourniquet placed on the injured limb above the zone of injury. We want that patient to get antibiotics as quickly as possible. As we know, time to antibiotics does impact risk of infection later. We want to update their tetanus, and then again, resuscitate the patient. They may require transfusions, especially if an amputation, it took a while for that patient to get a tourniquet and show up to A&E or the emergency department. And then once they're in the operating room, we want to perform an urgent sharp debridement with copious irrigation. Next slide, please. So the goals of our initial surgery are to retain clean, perfused tissue, preserving length whenever possible, because we can always shorten at a subsequent surgery. I think this is one of the most important points when we think about amputations. I think it's common in certain areas to perform guillotine-style amputations, which are shown here in the picture. And the drawback to doing a guillotine-style amputation is that in order to cover the limb, you have to shorten the bone. So you have to take more bone. So I'm a big advocate of always leaving whatever skin and soft tissues you can and performing your bone cut where you need to perform it, because you can always shorten at subsequent surgeries to get the limb closed. But we do know that, especially for the above knee amputation, the longer we can leave that lever arm, the patient's more likely to have a better outcome. Next slide, please. So we want to separate the artery and the veins. And for our larger vessels, so when we're looking proximal to the knee, we want to double ligate those. And that's typically with a stick tie, which just means a needle with a suture on it. That stick tie goes through the vessel, and then we tie it around the vessel, and then a standard ligature tie with just a suture around the vessel. And then for our nerves, we want to avoid group ligation, as this can cause problems with pain down the road, as they can have a pulsating vessel up against a nerve, which can cause throbbing type pain. And I would argue that the optimal acute management of nerves in the amputation is not known. I'd say the vast majority of people still do traction neurectomies, meaning we pull the nerve and then cut it sharply as proximal as we can within the wound, allowing it to retract within the muscle bellies. But there's still significant research in the area of nerve management to minimize postoperative pain, doing things like targeted muscle reinnervation and RPNI and other types of nerve management. Next slide, please. So the main thing for the amputation is you want to perform the amputation at the most distal level that will predictably heal. And this will be impacted by the zone of injury and the blood supply in that region. I'd say the two most common levels for the lower extremity are your transtibial and transfemoral, or below knee and above knee amputations. Next slide, please. So for the below knee amputation or transtibia amputation, it is extremely common in trauma. This is a very functional level, which makes it the preferred level of amputation for the trauma patient. We have transitioned, I think, over the last several years to do what's called a long posterior flap. And this can be identified and shown in the picture here, where if you take the diameter of the leg, add 5 centimeters, that's about how long you want that posterior flap to be. And the pictures that I show here on the bottom, you can see how that posterior flap, which has a better blood supply than the anterior flap, can be brought over the distal end of the transtibial amputation. And the benefit of this is that the suture line isn't directly right over the location of our bone cuts, which can potentially make prosthetic fitting more successful. The other thing we want to do whenever possible is to avoid split and skin grafting over an amputation. And that's just because of we can have problems with skin and wound healing. And then typically we want to have at least 10.5 or 11 inches from the ground to where we do our transtibial amputation. And this just allows for prosthetic build height with modern prostheses. And just a rule of thumb for me, I will take my hand and the width of my hand, I put my hand directly under the patient's tibial tubercle, and that is almost always where I'm going to make my transtibial bone cut in a typical adult patient. And that can guarantee that they're going to have enough room for that prosthetic build height. Next slide, please. So for the above knee amputation, the bone cut's going to be about 12 to 14 centimeters above the knee joint. And the reason why this is important is that'll give the prosthetist enough room to put an articulated knee joint within the prosthesis. Otherwise, it'll alter their knee center with comparison to their contralateral limb. We want to leave the muscles 2.5 centimeters longer than the bone when possible for closure. And this just allows us to close over our myodesis. And I like to perform an adductor myodesis, and I would say that's the standard for the US military. I know the UK military often does not perform adductor myodeses, but we do like to do that. So I do advocate for it. And typically when we do this, we're tensioning with the hip extended and adducted to avoid the deformity that you can see in this picture here, where the hip wants to flex and be abducted just because of the greater pull of the rectus and hip abductors with unopposed adductors. Next slide, please. So finally, I also want to talk about knee disarticulation. I think this is not commonly done in the United States. It is a very clean amputation with only one major blood vessel to control, your popliteal artery, and you have minimal soft tissue to dissect through, making it a nice option in the trauma setting. This is one thing that I really like to do in a patient that is hemodynamically unstable. So if I know that leg needs to come off as quickly as possible and the patient's going to end up with an above knee amputation due to their zone of soft tissue injury, I will often do a knee disarticulation at the initial surgery, just because I can do it quickly, get good vascular control, and then I can slow down and perform a good above knee amputation when needed. I do try and preserve the gastrocnemius, either the medial or lateral head, just to get soft tissue coverage over the distal end. I will retain the patellar tendon, and I suture that into the stump of the ACL bone or periosteum. And I think the most important thing in my experience with doing a knee disarticulation is you have to be working with a prosthetist that is more comfortable with fitting a patient with a knee disarticulation, just because a knee disarticulation prosthesis is going to be prepped a little differently than a standard above knee amputation. So again, I think ultimately the key here is to have a good working relationship with the person that will be making the prosthesis. And hopefully we'll be hearing a little bit more about that in our next session, specifically as it relates to RWANDA. Next slide, please. So with that, I'd just like to thank you for your time and attention and be happy to answer any questions at the conclusion of our session. Thank you.
Thank you very much, Dan. This was a very good presentation, and it allows us really to have a good grasp on the types of amputation which are really needed. We will have a short time for discussion at the end of this session. Basic question, how do you deal and prevent the neuroma? Maybe you can comment, both of you. How much experience of you, how do you deal with the prevention? Because sometimes can be a big trouble to our clients.
So I think Dan hit the nail on the head, that we don't know, actually. And I think if I was going to put another foundation in, I think pain and chronic pain and neuropathic pain is a really important element. So we, along with our US colleagues, have started doing a lot more targeted muscle treatment of nerve injury. We're getting in the UK now a pretty sizable cohort of our post-traumatic amputees who have this issue. But I do, as Dan does, you know, a traction nerve cut.
Yeah, so I would say, and just to add to that, we've transitioned to, so my clinical practice now, we've partnered with because we have a little bit of a different setup where we don't have orthoplastics like H to help me right away in the OR. But what I'll do is I'll do the acute amputation, and I will typically leave everything open. And then my hand colleagues who are doing our TMR here, they'll come back 2 days later, do the TMR and close the wound. So we've gone from doing TMR in the delayed setting for post-traumatic pain and neuromas to actually doing it acutely and actually seeing really promising results. So I think we're going to see a change where we start shifting from doing all traction neurectomies to doing more TMR, because it's relatively a simple procedure. I think people just need to be educated on how to do it.
Okay. Thank you very much for your answers. I see one from the audience who is asking about the number of prosthetists. I don't know exactly the number, but probably I know there are centers, I know at least like 1, 2 or 3 centers which are public, and probably 2 others which are private, which offer the prosthetic production and allowing people to get rehabilitation, proper rehabilitation from amputations. We invite more questions from the audience. We still have some time before we hand over to the next session. Audience?
I have a question from the audience, Jean-Claude, if that's okay.
Yes.
Specifically for Shihan H. There are a number of med students, in fact, Dan as well, if you could come in afterwards, this would be great. There are a number of medical students in the audience today listening to this conference. Would you have any advice for them as they start, this educational journey going forward?
Yeah, I mean, I think it's I don't know what to say really, because actually, as a med student, I started off doing this kind of work. As a med student, I went out to a war zone and got involved in prosthetic rehabilitation. As my last year as a medical student. I think it's a massive global challenge, as we all know. It's a massive global problem. So I think if you're a med student, wherever you are in the world, this is something that's a really important healthcare issue. And so I think it's important that if you're a medical student and you're interested in this kind of work, wherever you are in the world, there is a way of getting into understanding the challenges of this kind of healthcare burden.
I think just to echo that, I think one of the important things that we often miss as the surgeons is the post-traumatic rehabilitation. Because we often only see the patient at standardized intervals. I might see him at 6 weeks, 3 months, and a year after his surgery or her surgery. But the prosthetist and the physical therapist are working with that patient on almost a daily basis, or perhaps every couple days. So I think one of the things that's important for our medical students is to see the actual continuum of care for these patients, because they can identify what the real problems are, because often we don't see those problems on a day-to-day basis. So I think that would be helpful too, is just to spend more time focusing on the long-term care of that patient.
Thank you very much, Shihan and Stina. I think the other important question maybe to consider here is, what is your experience with amputations when trying to see further for which kind of prosthesis? Is it easily accessible in your respective environments? For us, probably what I may want to highlight is non-availability of very high quality prosthesis, which probably might interfere with the surgeon's choice when performing an amputation. What is your experience with the targeted surgery if you are targeting a high functional prosthesis?
So I would say that my surgery is no different. I think I practice in an environment that's I could probably guarantee is a little different than it is in Rwanda. But I am going to do an amputation the same way in a young active duty military personnel that I expect to achieve a high level of function, as I'm going to do in my 50-year-old trauma patient. My goal is to give them the best residual limb I can give them regardless. And then I essentially turn it over to the prosthetist who can reliably fit that patient in whatever prosthesis is is going to fit well with that patient's lifestyle.
I agree with Dan. I mean, I think it's really important that we break down this barrier between the surgical part and the prosthetic and the rehabilitation part. You know, they are a continuum, and the two elements, the surgical element and the prosthetic fit and prosthetic rehabilitation element, are intimately linked. So Dan and I, we're lucky, work in an environment where we do have good access to high quality prosthetics. We can do unusual amputations in the trauma situation. You may end up with, you may get away with less stable soft tissues because your prosthetic technology that you have access to will be able to cope. But I think the most important lesson is whatever you do as a surgeon has to be matched to what your prosthetist can and wants you to do. So the link has to be absolutely there, no matter what scenario we're in, because there's no point us doing an amputation that prosthetic cannot be fit to by the available resource. Conversely, there's no point, we want to be able to do the best amputation and leave the best residual limb for that patient, for that prosthetic service. So you have to kind of make sure the two processes are really closely linked.
Thank you both for your answers to the questions. I think our audience is still raising some concerns which need some comments about psychological stigma, rehabilitation availability, outcomes, adult versus young patients, and do we have access to prosthesis without going abroad? So all of this probably we can comment on. What I can say, as I was saying in Rwanda, we now have access to some types of prosthesis. I keep saying that prostheses are still very expensive, and probably they are not well insured by available insurance firms in the country, which currently offer access to only very basic prosthesis. So, of course, if a young patient by accident is required to be amputated, this becomes a very big tragedy for him and the family. And we need more than an amputator, we need more than a rehabilitation service, but we need also psychological support. We probably need to have people who are specialized into psychology for amputations, where young candidates need to be well convinced, prepared for surgery, as the outcome will depend on the status and emotional status of the patients. I don't have any data comparing old versus younger candidates for amputation, but what I know is, of course, for the young patient, it is even more difficult to convince in my practice. You have some comments to add on, Shihan and Steen?
Dr. Biringiro.
Yes, please, Emmanuel. Yes, you are welcome.
Thank you for your presentation. I have one question. Around 1995 in our country, so between 1995 and 2000, I have seen more person with disability, another person in Rwanda amputated more than 2 times. Maybe after 3 or 4 years, they do it. So my question is, what was the problem? Is it about our skin? Is it the problem of surgeries? And how is the situation now?
Okay, thank you so much. It's difficult to comment on your question because it's very difficult itself. Of course, in our practice, you can amputate more than once because at the primary amputation, probably it was guillotine amputation, which was due to the conditions of the limb. In some of the situations, like you have seen from the presentation from Dr. Sheehan, you can start by a guillotine amputation, and then later on you can adjust the amputation in planning for a prosthetic feet. So other than that, again, upon the advice mostly from the prosthetists, we can still continue to amputate, to adjust, and sometimes if there is bone overgrowth, especially in younger patients, we can again proceed to more amputation, but also we may go for amputation due to some other complications that can be due to either the technique, but mostly it is depending on the status of the soft tissues, as you have seen from our two previous presenters. I cannot say that there is no issue with skills because we do not have so many skilled people in the country for the moment. And as you can see, if you are telling me it was in 1995, you know, the situation in the country was at its worst situation ever experienced. I don't know really what was the skills available at that time, and can't say that it was a possibility to have errors playing a role in those repetitive amputations as well. Thank you very much for the question. Yes, Asimwe.
Yeah, thank you very much, dear Dean, and the two surgeons that has presented. My name is Godfrey Asimwe. I'm a prosthetist orthotist. I just came to highlight or to explain one of the questions that asked by the audience, one of the audience, just in the backyard. So he mentioned the availability of prosthetist orthotists, like the link between the P&O professionals and the surgeons in Rwanda. So I found that very important to explain it now, that in previous years, there was a gap of trained prosthetist orthotists on maybe university level. So most of them were not involved in the whole treatment of or rehabilitation of the amputees. So they were just left behind in the workshops or in their centers to just manufacture the prosthesis, but not involve them in the rehabilitation process as a member of the rehabilitation team. So far now in Rwanda, we have trained P&O professionals who are qualified, some with a bachelor's degree level, others with a diploma level, but with the knowledge and the competence to work in this field. So they know all the types of amputations, they know the causes, the pathologies, and others. So it's a high time for Rwandan medical doctors, especially orthopedic surgeons, to create a room for these people, also to come closer to the team, advise on the way of amputation if possible, how much tissue should be left, so that in the future, the using of prosthesis is best and functional for the service users. Thank you.
Thank you very much, Asim. I don't know if there is any other comments. Do you want to give a comment, Shihan?
Yeah, just one comment. So I guess really important point, because you know this whole process is a continuum that should end up with as functional a patient as possible after these kind of injuries. So they're back, as we heard earlier on, back to their life, close to their lives as they were before they were injured. And as a surgeon, you've got to understand that you're just part of that continuum and you're part of that team. And it's really important that the whole process is linked up and you have the right people at different stages of that patient's journey inputting. So, you know, it's not one point that's more important or one person that's more important in that journey than another. It's just that we have different roles to play in that journey. It has to be linked up. It has to be continuum. But also, everyone has to have that same end goal, which is a patient who hasn't just got a nice operation or a nice, residual limb after an amputation, but is functional and back getting on with their lives. That's the most important goal that we should all have, whether we're, whether we're the surgeon, the prosthetist, or the rehab team.
Thank you very much, Shihan. I think we have another comment from John from the Q&A. He was saying that his intention was to point out the lack of qualified prosthetists to consult with during or prior to the amputation in developing countries such as Rwanda. The result being a patient that suffers post-surgery due to the fact that they did not have the benefit of that consultation, resulting in a poor fitting prosthesis. Was pointing out that the mission of the human study was to provide the training to ensure that those resources are made available to the surgeon and the patient. What I can say about this comment is it is still a reality that even in some of the setting, probably consultation may become difficult, just as a cultural barrier rather than availability. Sometimes I have seen that in certain settings where probably people do not know much about even the work of prosthetists, and sometimes I see even among colleagues, surgeons who never visited a workshop for the prosthetists while they are available in a hospital. And it becomes even difficult for them to consult if they don't know what is happening on the other side of the hospital. Consultation is important, and it's another skill probably where we need to bring people together to be able to share about their practices, about the advances they can achieve in their respective fields. What I can give as a comment, consultation is there, but probably it's not at its optimal, and multidisciplinary care for the amputees is still a challenge, especially in our settings, because probably people are still few in their respective fields. Yeah, there was another member who commented, why cannot use telemedicine to reach an expert prosthetist in Europe or USA? I think these are again adult opportunities that can be brought by technology, and we of course need to embrace this as a team, and it's good that we come together to have the common understanding. Any other comments, panelists? So if so, I think we have been good with the time management. Thank you very much, Dr. Stina. Thank you very much, Dr. Shihan. You presented and shared a very good experience with us. I think the next session would be the next session would be moderated again by Dr. Dave. So Dave, the floor is yours. Thank you very much for giving us this opportunity.
Thank you very much, Dean Jean-Claude. Thank you, Colonel Stinner. Thank you, Shihan. Very much appreciated. Your talks were very motivational and very clear about how we go forward in this field. Jean-Claude, your moderation was perfect. Thank you ever so much for that. And it was really good to see such a perspective from the Q&A session. In terms of the conference progressing forward from here, the next session would take place in around about 6 minutes, and it's concerning amputee rehabilitation and clinical services. So we'll just take a short break to allow any refreshments, etc. And we'll come back and join at 5:15 Central Africa time. Thank you ever so much for joining us, and we'll see you in 5 minutes.
nkatwe tuba hano mu misozi rero urumva kugenda ahantu hagoranye biba bisaba proteze igezweho ifite flexibility yoroshye kugira ngo mu kwitwara wumve ikoroheye.
Amputation for me is something that is easily treatable. If there was better public awareness about what it means to be an amputee, there would be better resources for amputees. Life is a lot easier when you have prosthetics than when you don't.
And then it will become normalized, the way braces are, the way eyeglasses are. Even, I think, hearing aids are more normalized than prosthetics.
nkatwe tuba hano mu misozi
Hello, David. Can you hear me?
Hello, everyone, and welcome back to our conference. It's really good to have you here. I don't know about you, but I would say it's been an incredibly enriching 3 hours. So thank you ever so much to everyone that's joined us so far. Now, in this amputee rehabilitation and clinical services session, we'll have 3 presentations and talks from 2 others towards the end as well. So I hope you enjoy the next hour. Our first speaker is Mr. Robert Hakarimana from the University of Rwanda. He has been at the University of Rwanda since 2011, where he has been the head of department for 2 years. His teachings focus on subjects like anatomy and physiology, clinical sciences, prosthetic sciences, as well as orthotic sciences. Mr. Hakarimana is also the prosthetics and orthotics consultant for the University of Rwanda Center of Excellence for Biomedical Engineering and E-Health. He is the president of the Rwandan Society for Prosthetists and Orthotists, president for the African Federation for Prosthetic and Orthotic Professionals also. Robert, it's a pleasure to have you here today. Welcome.
Thank you.
I will bring your slideshow up momentarily. Over to you, sir.
Hello, everyone. I'm given the opportunity to present the clinical prosthetics in Rwanda, and I'm very thankful to the Imperial College London and the University of Global Health Equity. And this subject is really crucial. I'm happy to talk about it after the surgeon have talked, because it is correlating very much with what they have said. Next, please. Before I embark on the subject, I would like to talk about the background of P&O profession in Rwanda. P&O, as a recognized profession in Rwanda, is very young, 2016, but formally it was practiced informally since early 1962 with the foundation of HVP Gatagara by Father Frepon Ndagijimana, Belgium. And after 1994 genocide, only 2 centers could provide P&O services in Rwanda. Those are HVP Gatagara and the Center of Centre Hospitalier de Kigali. Next, please. The creation of 3 other centers by Handicap International was done after the genocide. And in 2011, the Department of P&O opened doors. Then in 2014, this school has got first ISPO accreditation. And now we are counting 68 P&O professionals in Rwanda, among them 4 Cat 1 and 64 Cat 2. And among the 64 Cat 2, we have 53 products from UR. Rwanda counts now almost 15 P&O settings, among them 4 public, 5 semi-public, and 6 private. Next, please. Now, I will talk about referral, but I couldn't talk about referral without talking about assessment, patient assessment. In Rwanda and in general, amputations are done without a clear perspective of prosthetic fitting. And I think it has been clear that no prosthetist is invited in the theater just to see what is happening and plan ahead what should be done for rehabilitation of the patient. The medical model is privileged compared to biomedical social model. There is lack of interdisciplinary team in the consultation room. Rather, we see the isolated individual action toward the patient treatment. And we can say that it is a multidisciplinary approach. Next, please. Now, before amputation is done, the patient is supposed to properly be informed about the process. This is not done because the process may be stopped on amputation, but there is no plan for rehabilitation. It is hard to imagine a good referral mechanism within a system where the interdisciplinary teamwork is quasi absent. Next slide. Now, this chart will show us what is happening in our settings in Rwanda. And I think in most of African countries, I've not got experience of Europe, but in Africa, the patient is with a surgeon, the nurse, and anesthetist in the consultation room, or then in the theater. And after amputation, sometimes he is sent to physiotherapist. Now, the patient sent to physiotherapists will probably get some muscle strength, and it will be sent to the prosthetist. The prosthetist will feed the patient and will walk slowly along, and we send the patient in the community. Now, my question is, what is happening when the patient is in the community because he has not prepared in advance on what is going to happen as a rehabilitation? I mean a comprehensive rehabilitation. Next slide, please. This chart now is picturing what should be done. The good approach, interdisciplinary approach, which is involving all rehabilitation actors, including medical, rehab doctors, nurses, anesthetists, physiotherapists, prosthetists, occupational therapists, medical counselor, and the family, even the community. Now, if you observe, there is a ring interlinking the professions. This is symbolizing the strength of exchanging, of sharing ideas, of consulting each other before any attempt to treat the patient. And now the arrows are symbolizing the action of each toward the patient. Next, please. Now, what we observe is really a poor referral. Most of the time, patient is discharged from trauma ward bed and sent straight home. Upon discharge, the P&O and the physio are not invited on board. Many patients are not even referred to physio for some care. So far, referral from physio to P&O is done, but is also following the same model, which is multidisciplinary approach. Next slide. Yeah, now when we go into the real practice of a prosthetist, I'm going to talk about casting. Casting is done in Rwanda manually or using some templates just to fitting the stamp. Then we observe that frequently the socket made is quadrilateral in different settings in Rwanda. The ischio containment socket, ICS, is rare and not commonly practiced in different settings. And you observe that the only material is still POP bandage and POP powder for just casting, being negative cast and a positive cast. Next slide. Now, I'm supposed to talk about delivery, but between delivery and casting, there is a long process of assembling, aligning the prosthesis. So they are a big process, but let's talk about delivery because it is multidisciplinary. Now, this delivery is done after fitting and some working exercises, but no yoga training is done. The ideal could be to have both P and PNO working together on fitting and static alignment and dynamic alignment and get training before the patient is discharged. More involvement of an OT at that stage would also be beneficial to the patient for functional rehabilitation. Next slide, please. Now, another crucial step is follow-up. There is what we call home follow-up and what we call center follow-up. The home follow-up is almost absent. There is lack of means, transport, and other expenses are not covered. So they look expensive. They look very, very costly to the government or other institution. And this is the reason why it is not done. Then on the other side, the client cannot afford those costs. Now, center follow-up is what could be done, but is not really done. The reason is sometimes to avoid additional cost to the patient, sometimes professionals have a heavy workload, and again, we have not adopted this culture. Next slide, please. Now, what is good now in Rwanda? Did we achieve? First of all, I will talk about political will. We have a government which is planning ahead just for a comprehensive rehabilitation. Now, currently there is an assessment by WHO so that we can develop the action plan and also, yes, the action plan for rehabilitation. There is also education. A good number of trained professionals is making a good human resource. Then there is a department which is continually P&O department at URA, continuing for qualitative education. Regular ISPO evaluation and school accreditation are also done every 3 years. Next slide, please. Good practices. Prosthetic services are provided and are improving progressively. Different disciplines are working toward a better for client multidisciplinary team approach. Partnership with different partners is boosting the progress. Then on regulation, we have Rwanda Allied Health Professional Council, we have the FATO, we have the RSPO, which are setting and regulating good practices among professionals. Next slide. What does it require for improvement? We need to develop the culture of interdisciplinary teamwork in rehabilitation to maximize on appropriate treatment for the benefit of the client. We need to train rehab professionals, mostly rehab doctors on ICF. We need also to put the patient in the center for rehabilitation so that he may make decisions about his treatment. Next slide. We need to educate with emphasis on interdisciplinary teamwork approach to introduce in the URA school different techniques other than manual casting. We need to emphasize on ICS as a type of socket, and the quadrilateral should be an option. Follow-up in the community should not be an option, but part of the rehab practice. On this note, I thank you very much for your kind attention, and thank Imperial College London and Global Health for this conference, important conference. Thank you very much.
Robert, thank you ever so much for that wonderful insight into prosthetics in Rwanda. Very much appreciated. Thank you. Please do stick around for some questions at the end of this session. Next up to speak is Major Pete Lefebvre. Pete is a physiotherapist in the Royal Army Medical Corps. Combined with operational tours in Iraq and Afghanistan, Major Lefebvre was instrumental in establishing the rehabilitation pathway for traumatic amputees returning from conflict. He was the clinical lead physiotherapist for complex trauma patients at the Defence Medical Rehabilitation Centre, working with complex combat casualties. He is currently completing his PhD at Imperial College London, detailing the amputee rehabilitation requirement and pathway. Pete, thank you ever so much for joining us. I will get your slides up right now.
Thanks, Dave. Thank you for the introduction and also for the invite to present at this conference. It's a huge privilege. So today I'm going to talk to you a little bit about the findings, really my experience of working over the last 8 years or so within Role 4 rehabilitation in the military, and also some of the findings that are coming from my research, the PhD at CBIS. Next slide, please. So I'm sure that previous presenters have talked about the innovation that took place in pre-hospital emergency care, which enables survival of many of our battle casualties, and therefore complexity of injury that we started to see in rehabilitation from that. And really, it was incumbent upon us as therapists to take this life that had been saved and enable that individual to then live that life to the full. And so really our drive was to enable these individuals to find a way to thrive. Next slide, please. And so in the course of this presentation, I'm going to talk a little bit about the process that really evolved over these years, the way in which it was configured around the person in order to optimize the potential recovery that resulted. Next slide, please. So defense rehabilitation is, it was established really seeking to take the injured soldier and recover them back to the front line and deployable duty. And it's underpinned through 5 principles. Now, the amputee is a very different category of injury to what we would ordinarily see, but what I want to do in this presentation is just show the application of these 5 principles to the amputee. Next slide, please. So first of all, early assessment, early treatment. Next slide. So treating operational casualties straight from Afghanistan, straight from Iraq, they will be at their optimum fitness and most likely critically injured, and the need to therefore preserve their function, preserve their fitness as best we can over the next number of weeks, really, whilst they recover before we start or commence the prosthetic fitting service was number 1 on the list, really. And this involved us going into intensive care. Physiotherapists ordinarily would have a role in intensive care anyway, but really, but beyond the respiratory, our respiratory treatment practice, we start to institute early exercise, even at a point of ventilation. Also, with this type of injuries we are seeing, the wounding that resulted from fragmentation injuries often would hold back casualties from progressing forwards. But elements such as the negative pressure wound dressing really made a great difference for us within rehabilitation, enabling us to commence our practice sooner while securing the wound. And on the left-hand picture, there's of course the prosthetic fitting, and once the individual got to Headley Court, to our military rehab facility, we chose to fit them straight away with bespoke prosthetics, and this really was to try and enable them to get up and about and moving as quickly as possible. But tempering all of these different points is the critical importance to attend to pain. And not to forget that if we don't manage pain, and we don't manage pain from the point of wounding, that this is going to store up problems for the casualty further down the line. Next slide, please. It was great to hear the previous presentation, brilliant presentation really, and emphasising the interdisciplinary approach. And I think this is still something in the UK that's really in its infancy. We very much in healthcare take this multidisciplinary approach in which clinicians operate in their professional domains, working in parallel with one another. But what we found working with this degree of complexity, working with casualties where we frankly didn't know whether the decisions we were making were the right ones, we found great strength and support from actually removing these professional domains, removing the physiotherapy department, removing the OT department, and actually clustering the specialties around one another in this interdisciplinary manner, which Robert brilliantly described in the previous presentation. And this is a process or a team process which we see in software companies, in a highly complex industry, and also which is wonderfully demonstrated in CBIS as well, that provides us with a disciplinary breadth as well as a specialist depth. Next slide, please. And so really when in my consultation with clinicians and clinical managers, it was probably not a surprise to see that overwhelmingly when they were talking about the components of care which were critical for our inclusion in future care pathway, we needed the interdisciplinary team was right at the top there, because it made a difference in terms of the innovation, the creativity, the support, and so on. And actually the interdisciplinary team challenged this idea which exists in healthcare again, the idea of care pathway, that we actually exist in a linear process. And I think this definitely is not the case when we're dealing with this degree of complexity. Next slide, please. The reality really for us when we were dealing with the battle casualty it was much more like this. It was highly complex. There was an extraordinary amount of concurrent activity and a need to ensure information flow to all the relevant places. Next slide, please. And it's interesting to have seen Robert's diagram and compare it to this slightly less well organized one, but it's saying the same thing. It's saying the point really with the IDT is it centers around the patient, and actually the patient is obviously the key component of this, and it's taking all of the professions in all their shapes and sizes, operating out of a process of consensus, where we found a great strength was able to be built from one another in this sort of complex unknown setting. Next slide, please. And certainly the literature talks about this interdependence that develops between professionals, this partnering, and really stemming from the sharing of goals, sharing of responsibility, sharing of knowledge as well between each other. Next slide, please. But this process there are two enablers really that come out within my research and certainly within the literature, and one is a need for leadership to be focused slightly differently. So leadership focused on the collaborative process, focused on nurturing trust. Next slide, please. And the team held within proximity. So finding ways in which to bring the elements of the team together. Next slide, please. So there's, and we were lucky at Headley Court that we were able to work in a common shared office space, but certainly when I was in the secondary care, it was much more difficult. And so these whole team meetings were having elements that allowed this informal discussion. The concept of stand-up meetings as well was particularly powerful, but especially down in theatres where there was an awful lot going on and the meetings couldn't take more than 10 minutes. You have the meeting standing up because people are much briefer and much more to the point. The importance of having coordination roles built into this process became apparent for us very quickly, and particularly nurse coordination and therapy coordinating roles. Of course, shared office space, shared coffee areas where what we want is informal opportunities to discuss other patients, social activities that build trust. But above all, the thing that really drove this for us was having opportunity for joint assessment. So as time went on, it became very rare for physiotherapy and prosthetics to be seen apart. With exercise rehab instructors and physiotherapists, we always assess together. So so having this opportunity of bringing individuals together in proximity so that this joint working is facilitated. Next slide, please. So when as I look at ways to model this idea, and I'm not saying this is the right way, this is just one thought I've had. I look at the contrast of the multidisciplinary team with its leadership at the top, delegating down to its constituent members and eventually clinicians, and I look at the contrast of how the IDT seems to be described within my research. Next slide, please. And we see instead the leadership actually forms an enabling function, a foundation upon which the clinical team, you can do the next slide, upon which the clinical team then builds. But actually each level is reliant on trusting the level below it, if you like. So, and I would also emphasize the importance of having the patient as part of that process. Next slide, please. So we haven't touched on prosthetic fitting at this stage, and we will now, but I think it's worth saying that we can have the best prosthetics in the world, we can have the best, the most beautifully fitting socket, but if the individual doesn't have the physical capacity to use that, or they don't have the skills to use it, then there's very little point in all of our work. And so really the foundation of our prosthetic fitting came from an exercise basis. Next slide, please. And so this was one-to-one with our exercise rehab instructors, with our physiotherapists working on power, proprioception, on joint range. But really the key point here is to target it at the individual and those individual needs. Next slide, please. And also immediately applying it into the prosthetic setting. So yes, we had prosthetic training sessions that were one-to-one, but a lot of what we did was actually group therapy, and the power of the group became very apparent to us as therapists and patients were able to work together and were able to learn together. And I think it's important to understand that this learning was both ways. And if you look at theories around communities of practice, I think it's beautifully represented and seen in this idea of group therapy. And so and also the learning that takes place between the patients was really important in this whole process. In terms of the actual prosthetic skills, when we were rehabilitating our bilaterals, we found keeping them as close to the ground as possible initially with stubbies, which is on the far left, and building them up with those stubbies without any sort of free knee or any sort of microprocessor knee involved in this. And then eventually they would have the physical capacity to then move to the long legs and subjecting them to environmental challenges, but in a way where we accept that they're going to fall. And this is not and we use falling as part of our rehab goal, really, is to teach them to fall well. But preferably in safe areas. And then once their skill builds, then to start to subject them to everyday challenges, walking down stairs without any supports and so on. preferably without falling. Next slide, please. So let's look at the individual. So no matter what we do, we need to, we sought to take this process and apply it to the individual, to their individual needs, their aspirations and their goals, no matter how crazy it may well have been. Next slide, please. It's very tempting, and certainly I felt this as one of the physios, that once we start to become familiar with our exercise planning, with our prosthetic delivery, that we become quite formulaic, and we forget this idea that actually what we're here to do is to help these patients thrive. Next slide, please. And you can do the next one after this as well. And really the way in which we sought to enable them to thrive was looking at, as we progressed their prosthetics and each stage of their prosthetic progression, was to look at how we could ally this with some form of functional integration. And I think I'm saying exactly what others have already said today. But certainly within this cohort, using sport and adventure training was a powerful way in which to do this and to build. And for these guys who are having to renegotiate their identity and discover a new identity, actually giving them new skills in an area they'd never practiced in, allowed them to positively develop an identity around something that they hadn't ordinarily participated in. And so sport became quite a powerful vehicle to enable us to functionally progress them in their prosthetics. Next slide, please. So we can skip this one. Thank you. So I'm going to just do a very brief case study on one of our casualties that are very well known now, and with some photos pulled off the internet. So, and I had the privilege of really being able to dip into his case all the way through, really. And so this young lad, 18, finished training as a Royal Marine, first tour of Afghanistan. He was point man in a patrol, stepped on a device and lost his leg. Complications led to him losing both his legs and also resulting in an extremely high amputation on the left. This, for someone who's in the Marines, this is an elite fighting force. They will they will stop at nothing to seek to achieve what they want to achieve. But to be held back by the fact that he couldn't walk well in his prosthetics due to his high amputation was something which he had to face and was incredibly frustrating through the early part of his rehabilitation. Next slide, please. This guy on the left is an exercise rehab instructor, worked at Headley Court with us. And his concern as he was working with these guys was that we were focusing just on providing them with exercise and rehabilitation to get them onto their legs, and we needed to give them something more, something beyond the therapy setting. And so he took his interest in Ironman and triathlon, and took these guys and decided that him and his team were going to take these guys and allow them to compete in, or support them in competing in an Ironman. And this is a photograph of him actually carrying this chap between different elements of the competition. But this experience of training with a team, this experience of competing, gave this chap something to connect to. It gave him suddenly a purpose, and he was able to start to form his identity despite his injuries, despite the fact he couldn't necessarily mobilize as effectively on prosthetics as maybe the others. This guy was fast, he was strong, and he had a talent for this particular sport. So next slide, please. And really, as a result, this mountain of a man you now see here represents Great Britain in triathlon. And I think for me, as I look back and I look at the way in which he adjusted to his disability and the challenges he faced, I can't help but think that the critical points in his journey really were Mark was undoubtedly critical in directing or helping and facilitating him into an interest which allowed him then to take his own rehabilitation forward. Next slide, please. And you can do the next one as well. So in terms of the wider population, where are we at with our battle casualties? Well, This is some of the baseline data coming out of a 20-year longitudinal study, which was looking at 6-minute walk distance, and I haven't got the comparative stats up here, but just data that we took from Headley Court at the end of their military service, and this is data 5 years down the line, or 3 to 5 years down the line, is very comparable with this particular outcome. And so we still, and the blue area is walking a 6-minute walk distance that a healthy population, clearly I'm talking too long here, that a healthy population is able to achieve. And so we've got still 50% of bilaterals and 50%, 43% of triple amputees achieving healthy a distance over 6 minutes equivalent to healthy population. So, and this is really quite an achievement, but our challenge really now in the rehabilitation setting is how do we support this cohort to be able to maintain their skills and maintain their fitness. So hopefully within this presentation, I've been able to talk roughly around the process involving early intervention, collaboration, coordination, and an agile approach that's centered around the person and the person's physical and mental and social needs to be able to enable them to optimize recovery. Thank you very much. And again, thank you. It's a great privilege to be able to present to you today.
Pete, as a personal friend and a former patient of yours, thank you ever so much for that very informative presentation. Thanks again. Next up to speak today, we have Michael Stevens. Michael is a director of the amazing social enterprise Jumping Kids, based out of South Africa. This organisation provides mobility and prosthetic solutions for child amputees. Now, Michael, I've seen your slides, so I don't really want to get ahead of myself here. So I'm just going to bring your slides up and hand over to you. Thank you so much for joining us.
Thank you, Dave. Good afternoon, ladies and gentlemen. Thank you for the opportunity to connect today. It's wonderful to be able to chat with you about something that's so important to me, because you see that I believe that people, but especially children, have infinite potential. But what happens when all that potential and all that latent talent is trapped in a body that society would look to define as broken or disabled? A body seen by most as full of limitations rather than something that has potential. How could that potential be found? How does that person reveal their best self? Next slide, please. My name is Michael Stevens, and I'm the director of Jumping Kids, a non-profit that provides and maintains highly functional quality prosthetic equipment to amputee and disabled kids across South Africa, and a few in Africa as well. Jumping Kids was founded in 2009 by a prosthetic professional named Johan Snyders. Johan had been working for a major international prosthetic manufacturer and had developed a direct lamination socket manufacturing technique he thought would be beneficial to the issues faced by amputees in South Africa. When he returned and opened his practice, however, he noticed that a large number of amputee kids were being referred to him. And it became clear that these kids and their families could not support or afford to subsidize the costs involved with the equipment that he knew would make a fundamental difference to their lives. So Jumping Kids began. And I'm not him, so in order to understand how I fit in and why I claim to have some knowledge to share today, I need to take you on a little bit of a journey. But given our time, I'll make it very abbreviated life story, I promise. You see, in 1992, whilst being a 12-year-old kid, I was electrocuted by high tension wires. I suffered third-degree burns to 70% of my body. And that was 28 years ago, so I clearly survived. But I left the hospital almost a year later after that accident with a different body. I weighed 16 kilograms, my left leg was amputated 10 centimeters from the hip, my right leg 6 centimeters from the knee. I had significant muscle loss in what was left of my legs, as well as in my back and on my shoulders. I had scarring over most of my body and would endure 2 more years of hospital as doctors tried to fix me. So on the face of it, and according to everyone but myself and my closest people, I faced a lost and limited future. Now, I'm trusting the fact that I'm here and have been given some time among such esteemed speakers gives me an indication that my life has not been so severely limited by my disability. And in fact, I like to believe that I've lived quite an exceptional life. I've gained 3 educational qualifications, traveled the world, worked for big global brands, built Jumping Kids, and competed for my country in sports. However, this presentation is not about me or my life, but rather mine and Johan's belief that others need the access and opportunities that I had as a child. Access to fundamental basics like mobility equipment, maintenance services, and a route to education and sports participation. Because if more disabled children are given access to what we see as fundamental rights, then it will stop being exceptional to just see people with disabilities out in the world, in their communities, integrated and living their lives. This should be the norm, not the exception. We need greater acceptance that kids and people with disabilities in general are capable in life, in education, in sports, art, and culture. A South African Oxford scholar and disabled advocate, Eddie Ndopu, explains what I mean by saying, I'm exceptionalized because the overwhelming majority of young people with disabilities are denied the opportunity to live their best lives. So people want me to be the benchmark for what people with disabilities can achieve, instead of addressing the socioeconomic issues that make it difficult for there to be more people like me. And this is why Johan and I developed Jumping Kids in the way it approaches working with our beneficiaries, their families, and society at large. We want to bridge that gap in order to provide mobility equipment and development opportunities in education and sports to kids who normally wouldn't get the chance. In South Africa, if you are reliant on the state for a prosthetic solution, you are going to be in a waiting period of 3 to 5 years. And once you have a solution, there is no guarantees on the fitment or the components used. The sockets soon become, non-workable. And this is an unsustainable and ineffective model. If they aren't able to get the equipment and be mobile, then kids aren't attending school. In fact, without equipment, amputee children are often excluded from attending school. Their potential is questioned due to people's perceptions of their ability to cope in a mainstream environment, and the lack of facilities to handle mobility use are used as an issue for them attending. With no education and a disability, they can be led to believe that they have no purpose, no dignity, and in many cases, they can be considered a burden. If an amputee child has access to quality prosthetic equipment and services to maintain or replace damaged goods, then this need not be the case. This is why there are 3 pillars in Jumping Kids philosophy, all revolving around giving access. Next slide, please. Jumping Kids' mandate is to give amputee children access to mobility, access to education, and access to sport. When starting with the beneficiaries, there's a general process that we follow that is repeatable and consistent. All Jumping Kids start with an application form being completed by their parents or guardians that give us an understanding of their situation. We would then go through a full assessment of the amputee with an interdisciplinary team, including multiple viewpoints, to really understand the mobility solutions and options, logistical challenges we may approach, and the rehab we should use. We fit and do the rehab in one session. Johan was integral in developing a fiber braid-based direct lamination technique for socket manufacturing, and we use this in most of our work. It allows for the socket to be made in 1 hour and directly on the amputated leg. This technique is key for time management, as the kids can come from very far and wouldn't be able to get back to us if we had to do multiple appointments just to make one solution. It also allows us to fit in rural and remote areas that may not have electricity or running water. And this is important, as this is a reality we face in wanting to service amputees in these areas. Making the sockets and being able to assemble and fit within hours means that the focus can also be shifted to rehab. On the same day they are fitted, they are taught the fundamentals, like how to use and care for silicone liners, how to take the leg off, put it back on, and going through walking techniques and terrain management. This gives them a head start and improves the outcomes that we see from them. After the first fitment, the follow-up is then in about a month, and if everything is good thereafter, every 3 to 4 months. This lets us check the liners and keep the leg functional. We can make sure that things can be fixed before they break. As the kids get used to the solutions and their mobility improves, that's when our focus will then shift to education, sports, and other activities to get them to really use the equipment and test themselves. Next slide, please. Those are the principles of Jumping Kids mandates, and we do as much as we can with the resources we have to give as many opportunities to our beneficiaries as possible. Over the last 11 years, we've fitted over 200 amputee kids, and we're currently maintaining the equipment of around 110 today. Funding for this is privately raised through fundraising events, appealing to corporate social investment, and through the generosity of individuals. We have amazing stories to guide and inspire us to continue. And to highlight the impact of our interventions, I'd now like to introduce you to 2 of those. Please meet Sandile. Next slide. And can you play the video?
Igama nguSandile Mbili, ngihlala eTipsloot number 5, ngineminyaka ewu-17. 4 years ago, ngiluze imlenze due to infection. I thought I was going to be in a wheelchair for the rest of my life. Until ngathola ama-prosthetic leg kwa Jumping Kids, impilo yami ike yatshintsha kakhulu. Ukuqala wami ukuwalka bekunzima ngoba bengingasahambi isikhathini esiningi. UNedbank baye bangibekela i-track phansi eyayinemiyalezo yakwi-Twitter ebizwa nge-Twitter track. Le Twitter track yayinemiyalezo evela kubantu ku-Twitter ababengigqugquzela ukuthi ngihambe. Bengakholwa ukuthi kunabantu abangithanda kanje. And futhi mina labantu angibazi. Now I can walk, I can run, and people can't believe that I can run already.
So Sandile is a jumping kid from rural KwaZulu-Natal. And for 4 years, he was basically left to fend for himself during the day, moving around his small home on his hands and knees, unable to go to school and shunned by his community and society. His sister moved him to Johannesburg in the hope of changing that. And when we met him, we saw that he was a perfect candidate for prosthetics. His amputations were done well. They were both below the knee, which I consider to be an easy fix. He was young, willing, and determined. And though he shook uncontrollably for his first steps that you saw, within 2 weeks, he had left his wheelchair behind to attend school. Within a month, he was beginning to jog. And after 5 months, he ran just over 2 kilometers as part of that campaign that we did for the Comrades Marathon. Today, he's completing school, walking well, able to run, and he takes part in various events with us. However, Sandile is a below-knee amputee. What about above-knee amputees who have greater challenges? Prosthetic knees have come a long way, but most people wouldn't even get to experience a decent one because of the cost constraints involved. To give you an example, the knee that I use was developed over 20 years ago, and it's still better than most amputees will be able to access. Mechanical knees also take time to learn how to use, so falling is common. If a young child falls too often, they lose confidence, and with that, the ability to walk effectively. We felt that a new thinking or approach was needed. So we wanted to do this with one of our beneficiaries. Next slide, please. Ntando was born with hemophilia, a birth defect that left him with deformed lower legs. We met Ntando at our clinic that we have at Steve Biko when he was 10 years old. He was overweight and understimulated, but happy, polite, and interested. We asked him what he wanted to do if we were able to assist him, and he said, "I want to play soccer. I want to run." We told him that we'd work to make this a possibility, but in order to fit the prosthetics, we were going to have to amputate the deformity and make him a through-knee amputee. He told his grandmother and his mother that this is what he wanted to happen, and the process began. Next slide, please. With the amputation complete and Ntando's wishes to run in mind, Johan decided to fit him with blades associated with athletics rather than going the traditional route of starting with stumpies or going into walking legs. It was also decided not to fit prosthetic knees in order to avoid the issues around falling when the knee collapses. This taught us so much. In his first fitment, Ntando walked with the blades. Within weeks, he had found a rhythm and he began to jog. At one of our events, a mere few months after being fitted, a group of our jumping kids had a race to the bus. Two of our sports academy athletes, much older than Ntando and single below-knee amputees, took off. Ntando followed, and by the time they reached the car, he was right up next to them. My comment to Johan at the time was, "That's the fastest double above amputee I've ever seen." Ntando has become proof of the concepts of Jumping Kids 3 pillars. Once his potential began to show, we embarked on getting him into a mainstream school. With the blessing of his grandmother and his mother, Johan welcomed Ntando into his home so that he could attend Johan's children's school. I committed to the school that he would always have equipment and we would manage any issues, and everyone that had needed to agree to make it happen did. Next slide, please. With mobility and education taken care of, we began to focus on sporting opportunities. Our sports academy brings amputees together, adults and kids. We take part in events year-round, including international events. We make sure the kids have the equipment to be competitive. The speed of Ntando's development once he was in this was unprecedented. From his first step at the age of 10 to a silver medal at the Rio Paralympics at age 14. Mobility gave him access to school. School let him develop his mind and reveal his intelligence. Sport let him build a strong body and reveal his talent. And he is now a confident, well-rounded, incredibly capable young man who is anything but a burden. His success showed the benefits of fitting double amputees with blades, and that this is often the best option for them. It gives more mobility and lets them really push themselves. It's highlighted that prosthetic thinking is moving towards function rather than form. It's about what it lets you do rather than what it looks like. It should not be a matter of it should not matter that the prosthetic doesn't look like a real leg. It's not a real leg. What matters is what it allows you to do. We have subsequently fitted multiple other double above knee beneficiaries with the blades, and the results have been amazing. There is only one Ntando Mahlangu, but he proves that with the Jumping Kids 3 pillars in place, you can blaze a path for others. Next slide, please. Play the video.
Msiginyeko. Akinakaro kekhulu yokujama ndawonye. Vele nje ukujama ndawonye akusindwe yami. Ngabelethwa umzimba wami ungivimbile. Abanye bathi nginebelo ngenxa yenyawo zami ezi. Eqinisweni konke kusengcondweni. Angikusabi ukubhalelwa nobuhlungu. Nakuzubuhlungu ngithi, oh, you again? Awu inyawo ngizifuni. Zigenza ngibe buthaka kakhulu.
When we are free to move, anything is possible.
Next slide. Ladies and gentlemen, the reality is the way in which the world's prosthetic industry and its surrounding business ecosystem has developed results in many amputees being excluded or receiving an ineffective prosthetic solution. Children and adults combined. Considering the difference having quality equipment makes to the lives of amputees, their families, and society as a whole, this seems fundamentally wrong. An international research paper explains part of the issue by saying current solutions are inadequate. State-of-the-art solutions from the US and Europe are cost prohibitive, while low-cost devices have been challenged by poor quality and unreliable performance and have yet to achieve large-scale impact. A further issue, especially in the developing world, is a lack of skills available to manufacture effective sockets and assemble the equipment. There are too few highly skilled graduates coming through the system, and unfortunately, I believe current curriculums and techniques the institutions teach are antiquated and need revision. Apologies. Next slide, please. Next slide, Dave. Thanks. Through my life and experience, I've experienced the difference using quality components makes. With access to quality equipment and maintenance support, I do not see that anything that can't be tackled. At this point, various amputees have climbed Everest, a place you go to lose limbs, not test alternative ones. Sorry, Dave, just one back slide. Thanks. Socket technology has changed and there are more suitable methods in place to deal with the issues we face. We have better materials to consider, which are more durable, comfortable, and easier to work with. Workflow has changed, meaning we can do more in the same time when we embrace these changes. Business models can be changed, making it possible to offer better solutions to those who previously only got low cost, low quality. Next slide. Ladies and gentlemen, we have a plan to give access to more children amputees. We can do it, we will do it because we must do it. The equipment and services required already exists, so there are no worthwhile excuses on this issue. We must give access to better prosthetic equipment and services to more amputees. We need to partner together to gain the scale required to deal with the problem and change the cost structures. Together, we can work towards meeting UN development goals around access to health services and equipment for vulnerable groups like the disabled. We can disrupt the industry while striving towards much needed transformation. We can create jobs and develop skills in Africa to handle Africa's amputation issues. The solution requires governments, private organizations, tertiary institutions, and nonprofits to talk, to collaborate, to pool our resources and make sure that the barriers that exist to limit access to quality equipment and services are broken down. Jumping Kids is ready to contribute where we can to be a part of this solution. Next slide, please. Amputation and disability is not the end. In some cases, it might only be the beginning. All children deserve a future. All people deserve a chance. We cannot discard their potential just because on the face of it, they have a disability. With access to effective equipment and services, anything is possible. Access creates opportunities. And with the correct access to equipment, those people who were thought to be broken may just surprise us all. I hope to work with you to solve these issues. I thank you for your attention today and for the opportunity to speak. Have a great day.
Michael, thank you so much for that presentation. Absolutely incredible. The work that you and the team at Jumping Kids are doing is just phenomenal, and the viewpoint that all children have potential, and that potential should be explored and encouraged as much as possible. It just shines through there. So thank you for everything that you're doing. Just to close off our session today, we have two more speakers from the National Institute of Health. First up is Dr. David Crandall. Dr. Crandall is an assistant professor in the Department of Physical Medicine and Rehabilitation at the Harvard Medical School and a physiatrist at the Spaulding Rehabilitation Hospital in Boston. He is the medical director of the amputee program and an attending physician on the comprehensive rehabilitation program, where he works with patients with limb loss and a variety of musculoskeletal trauma. Dr. Crandall, over to you.
Thanks, David. Hope everybody can hear me. I really appreciate the organizers for allowing me just a chance to say a few words. I've been sitting in my office waiting for today's admission, and this is very inspiring. I also want to obviously specifically thank Claudine, who actually worked here at Spaulding 7 years ago at a very challenging time in my professional career. We got to experience the after effects of the Boston Marathon bombing, and we had a high number of traumatic amputees all at the same time. And Claudine basically volunteered. She was our first intern on the comprehensive program, and it's really wonderful to see how she's developed in the program that she's put together today. So I really like to give her a shout out for that. Again, listening in my office, it's been quite a great morning listening to various speakers. Again, having been involved working with amputees for a number of years, I think there's lots of themes that I think I'd probably like to just to focus on just briefly. One, people talk about it as a process. Rehabilitation itself is a process. People were talking about the continuum and trying to find a link in that process between surgical techniques and ultimately fitting with an individual with a prosthesis. So this is sort of an opportunity for me to plug our specialty of rehabilitation medicine. Being a physical medicine rehab physician, we feel that we have that role to help bridge that those gaps and make that link. And again, the key features I think we're already talked about a lot this morning were probably the focus on the individual. One of the things that I say to some person who's newly had an amputation is that clearly amputation shapes them, but doesn't define them. And I think that was very much demonstrated by the various speakers today. People talked about getting their life back. Well, it's life as they dream it and they live it. I guess the other theme is talking about education. I think one of the biggest things I do in my daily work is actually educating the patients. They come to us in a situation where they're kind of, it's the uncertainty, the unknown. They just had an amputation. They don't know what that life is going to be like. They're going to wake up every day newly as an amputee. And I think we can provide some of that basic information to sort of guide them through their process. One of the ways that we also do that is through peer visitors. We have had people who have been successfully through our program come and meet with our patients. It's been a little bit challenged to do that now in the area of the pandemic, but we've actually arranged for people to do peer-to-peer visits over Zoom. And so I think that's something that's really important for people to make that connection. And I think the other obviously thing that people are talking about, the interdisciplinary team. I'm sort of biased. I feel that we should expand that team fully. Here in Boston, we have the opportunity to have direct communication with the surgical teams. I'm directly involved in a interdisciplinary surgical clinic at the Massachusetts General Hospital. So I'm there as the surgeons are trying to make their planning. And sometimes the best option is to go forward with the amputation, and we can talk about what their experience is going to be like after that. In our clinic setting, again, during COVID, one of the challenges is how do you create an interdisciplinary team if everybody can't get in the room? And we've been using Zoom technology to actually have the prosthetist still be present when we're making decisions on componentry. Clearly, after Michael's last presentation, I'm also the medical director for the adaptive sports program. So every amputee that comes into our program, obviously we're trying to push their opportunity to participate in sports. And, during the season here in Boston, we can actually get people back out in a hockey rink. They may have been up in hockey players before, but that's something we can try to do. In the summer, we're right on the access to the Boston Harbor. We can get people out actually in kayaks and on windsurfers. So when they start doing an activity that in some ways they've never envisioned doing before, that is a lot to convince them that they can really be successful. And I think the last part, obviously the focus of today is talking about training. We have the opportunity to work with medical students, residents in physical medicine rehabilitation, but we're also trying to expand that training to advanced fellowships. I don't know if people can see behind me, there's a whiteboard. That's the outline for a new amputee rehabilitation fellowship that we hope to start in July of 2021. And that's really to give an advanced clinician the basic skills to go and start a program throughout the country. And we're going to use the best training both in the civilian model, and of course we've heard a lot today about the military experience. Built into that fellowship is going to be the opportunity for that fellow to do rotations at the Walter Reed Army Medical Center. So they're going to be able to take the best combination of both civilian and military experience and put that forward. And so, that's my comments today. You're going to hear tomorrow from Dr. UGHE at MIT. He's involved with a surgical program here in Boston. And one of the patients that hopefully you'll hear about maybe even tomorrow is the first patient to have both legs amputated with what's called the new Ewing amputation. And according to my pager, he should be here anytime soon. So I'm hoping to be able to work with him directly. In this ideal situation, I have met with him twice prior to his amputation. He's been in the building. He's had a positive surgical experience, and now he's ready to transition to his the next phase of his rehabilitation. So again, I really appreciate the opportunity. Claudine, keep up the good work, and I hope to continue to work. And I'm very inspired to work with some of the folks I've heard today. So thanks.
Thank you.
Dr. Crandall, thank you ever so much for those words. Next up to speak is Dr. Teresa Hayes-Cruz, the Director of the National Centre for Medical Rehabilitation Research. Dr. Cruz, thank you very much for joining us.
Thank you so much for inviting me. Thank you, Claudine. This has been an incredible experience this morning, listening to all the speakers. I am an engineer by training, and I direct the National Center for Medical Rehabilitation Research at NIH. So I have a deep connection to assistive technology and the rehabilitation specialists that contribute to making those technologies work for functional recovery of people with amputation and limb loss. We fund about $10 million of research this past year in prosthetics. Most of it is in the development of new technologies. And I definitely heard today that there is a need for that, especially in new terrains, inclines especially. We also support research in the care of the residual limb. I heard a lot about pain today. We have particular research projects through our HEAL initiative to reduce pain. And then, in general, how to rehab prosthetic users. How can we prevent falls? How can we teach them to get the most function? And then, of course, while we're developing all these technologies, we have to think about how we're going to deliver that care, how we're going to implement them. We've heard about the high costs and the lack of services. And if we're not thinking about those issues at the outset of our research studies and design, then we're not going to get these technologies to the people who need them. And I think that's been mentioned a few times about we have a lot of well-meaning people, but they're not engaged enough with the end users. It's an incredibly, unfortunately, universal theme. Whether you're in a low or middle income country or not, we hear that users are not included at all stages of research as they should be, or care delivery, that we need more data we are in the third year of trying to develop a registry for limb loss and preservation in the US because we don't have enough information about amputation surgery through whether a person is recommended for prosthetics, to what kind of device they get, to what kind of rehab, and then of course what kind of outcomes, because that's what we're all here for. We heard the surgeons talk about it. It's not just about a pretty surgery. We'll probably hear more from the engineers tomorrow. It's not just about an elegant device. It's about the outcomes for the patients. And then I know we're over time, so I'll be brief. As if the incredible personal experiences that have been described today aren't enough to encourage people to do more. On Tuesday, The Lancet published the global burden of disease estimates for people who could use rehabilitation. And they estimate that there's 176 million people living with limb loss for over 5 million years of life with disability. So I think there is just a huge need for research and work to give those people the greatest function possible. So thank you again. It's been a privilege to be here, and I look forward to tomorrow's continued presentations. Thank you.
Dr. Cruz, thank you so much. Those figures are astronomical, so thank you for highlighting those. As you said, we're slightly over time, but I think there's still a few important questions which I think I'd just like to ask, some from the audience. Robert, first off, I've got a question for you. You talk about community follow-up as part of the rehabilitation practice. Rwanda has a robust community health model. How can community health workers engage in supporting amputees in community settings during their rehabilitation?
Thank you for the question. Actually, the community we talk about is the administration, local administration. There is the family. We talk about the surrounding friends and relatives. All those should be involved in rehabilitation, because psychologically an amputee is somehow disturbed and needs a lot of support, and also be accepted in the society. We used to see those people here in Rwanda called ibimuga, which means a broken vessel, which doesn't serve for anything. But these people, they can be rehabilitated functionally and respond to the needs of their family, cater for their family, support economically their family, and also the country. That's where rehabilitation and follow-up should be done, to know if these people have been integrated in the community to serve as they used to be, so that they feel that they are valued, they feel that they can do something for the community. That's where rehabilitation in the community comes in.
Thank you, Robert. And that's such a key point. It's easy to consider an amputee as an individual, but it's very difficult often to remember that around an amputee is a family or a community that are affected by that person's condition as well. So I guess the key point there is that the amputee should never be considered in that context, that this condition, this situation affects only them. Thank you for that.
Exactly.
I've got a bit of a question for you, Robert, for Pete Lefebvre, and for Michael, actually. It's a bit of a tri-pronged question here. How easy would it be to implement phased prosthetic skills and sports rehabilitation in low resource settings like Rwanda?
That activity needs more involvement of stakeholders, partners. And currently we have ICRC PRP program, physical rehabilitation program, which is supporting some national team to get these bicycles, not bicycles, they are wheelchairs. just to be involved in some sport activities, but also there is plan ahead. We have a national team which is also sitting volleyball. They are involved in sports. All these are the activities that can help them to feel valued and feel that they are integrated in the community. We are looking forward also to lamination technique, and we hope that with that lamination technique we can use even carbon fibers processes so that we can equip some and train them with the help of partners, and they will be involved in athleticism and other sports activities.
Thanks, Robert. And perhaps the socket technology that Michael and Jumping Kids use could be very useful in this aspect.
Yeah, this is one aspect I appreciate, because we have been put together. We have shared, and I think with our colleague from South Africa, we can interlink and see what we can do for those people. Yeah.
Thank you.
Thank you very much.
Pete, is there anything you'd like to add about sports rehabilitation?
I think the main thing I would add, actually, Robert's just brought up there. I think this sort of venue and this ability to network across different countries and learn from one another is incredibly valuable resource. So listening to the work that we've been doing in South Africa with Jumping Kids and how that could apply into Rwanda and vice versa, and equally, you know, the technology, prosthetic technology that Michael's suggested here, I would be very interested in us trialing in the UK in that way. And so I think it is about having this international discussion and network where we can share ideas and be innovative in how we apply them. So yeah, that's all I think I would add.
Thanks, Pete. Michael, are you still there? I've got a specific question for you.
I am. My camera's up, but
no worries. Okay, so this question is from Bethany in the Q&A session. Sport is such a great way to support rehabilitation, but it tends to be exclusive of women. How and what could women in low and middle income countries engage with that would enable the equivalent aspect of rehab?
Well, I think that part of that is a societal issue as well. You know, we need to include more women in it. So we need to be giving the equipment and the opportunities that we may be given to younger boys and, you know, to girls as well. In what we do, we see that generally there are more young boys who are amputeed and disabled than young girls. It's kind of a 70-30 split. You know, lots can be said about the intelligence of men and all of those, you know, fun jokes can be made, but that's what we see with the kids that we fit. I think it's an inclusion issue. We need to get them the equipment. We need to get them in school. We need to give them the opportunities to take part in sports and be a part of it, even if it means they must run against the boys.
Thank you for that, Michael. Emmanuel, I can see your hand up on the screen. Would you like to ask a question?
Okay, thank you. My question goes to Robert Hakorimana. I have seen you have different partners, but I have not seen a Otobok. In our country, we have opened a new referral rehabilitation center in Gahini, where Otobok provide equipment with the latest technology. And they train the practitioners, and they wanted to support us to upgrade other orthopedic workshop we have in the countrywide. So I think I don't know if you have some relationship because it's a good partner in our country. And the second question is to the Major Peter Lefebvre, and it's in line with the presentation of Michael Steven, Jumping Kids. Really, I appreciate your support in the sport rehabilitation. In our country also, we have focused on sport for persons with disabilities because we know they facilitate not only in a good life, but also in a they can stay with stigma, with discrimination. When they go together and they play, at least they can share the challenges they have, and they can participate in their development. So actually, we have developed the sport for persons with disabilities with the National Paralympic Games. We have 49 city ball teams. We have 30 teams of sitting volleyball, and we have we have 7 teams of amputees football. So I am saying only for persons with the amputees. So, but we miss some sport because of lack of materials or rehabilitation materials. I have seen the presentation of jumping kids, where they can the kids should do the marathon. This is not done in our country because we have those assistive devices, those prosthetic, those adapted prosthetic for the kind of sport. So I should invite them if they can come in Rwanda and support the promotion of that sport. Thank you.
Thank you, Emmanuel. For your question, I would like to mention that actually there is tomorrow another presentation from Dr. Jan, and she will talk about that partnership with Autoboc. And actually, Autoboc has helped us to develop like a plan for different workshops, including Gahini workshop, and they are potential partners also for the Center of Excellence, which is being constructed now, whereby it's a Center of Excellence for biomedical engineering, and it will be training different teams, different professionals in rehab, and Autoboc is playing a big role. So it's a potential partner. Thank you for reminding me, and I apologize for forgetting to mention them. Thank you.
Thank you for that, Robert, and Emmanuel for your question. Being mindful of time, I will draw today's session to a close, but just remind everyone that we continue back here tomorrow at 4 p.m. Central Africa time. We'll be discussing prosthetic technology, we'll be discussing education, and we'll be discussing prosthetic design and research. So it just leaves me to say thank you to all of our speakers, and thank you to all of our attendees for joining us today. Good evening, and we'll see you tomorrow.
Thank you.